at the same time to make a difference. In the medium term, we talked about improved intake and assessment processes. Some of the systems that you'll hear about later will, have made attempts to change that in their states. Improving the data, but there's been some progress on that already, and there are some data dashboards that are coming up. And then expanding FQHCs and allowing them to get the encounter rate for a broader range of services was another one. Longer term, really getting clear on those roles and responsibilities and addressing kind of this problem of, it's their responsibility to take care of this kid, that kind of thing. Improving support for tribal systems of care, and then improving the coordination between fee-for-service and managed care. And we'll talk a lot about that. But overall, just a system of care that maps to the needs of the child. And systems evolve, right? They're organic. They don't, we'd love to say that the system was designed, or maybe we wouldn't love to say that because it's, it's not meeting the needs of children today. But this is an evolved system that organically grew. And your task is to work together to try and design a system that works better. And that brings us to a break, but I think that might be a little bit early for that.
Yeah.
We can just kind of keep on going. So let's move ahead to the next slide. And Uma, I think this is where you take over.
See, that's not your toy. Okay.
Can folks who on video who are not speaking mute themselves? I think it would be super helpful. Thanks, everyone. Okay, so the next few slides, I see so many familiar faces from my interviews. I just want to say shout out to everyone for all your candid conversations. The one other strength that wasn't mentioned there was Medicaid's willingness to bring everybody to the table. Because lots of people said it feels like a new day. So I do want to give a shout out to Suzanne and her team because they're, it's not always easy to crack the Medicaid nut, right? I was on the child welfare side. I know how hard it is, but to have this conversation is super exciting. Okay, so what's a functional children's system of care? It's a continuum of services from prevention to treatment, from crisis to acute and inpatient, right? All across, seamlessly going in and out based on needs of children and families. And to have coordinated connections across levels of services, providers, peers, and managing agencies, and child and family centered, always putting the children and the family at the center of everything that you all are designing. So connecting people, the right dose at the right time, right? That's always the toughest thing. So let's talk a little bit about some of these elements of the successful cross-system collaboration. I love that little girl's face. So I use that slide everywhere I go. It's just precious. So the right dose at the right time for the right problem. So that's why you need to go upstream and you need to go deep end. Trust across departments. Child welfare, behavioral health, and Medicaid often at state levels do not plan together. It's really hard because your mandates are different, your funding streams are different, you think differently. So that's another really important piece. Prevention. Everything's moving upstream now. Human-centered design and prevention-focused work. Data sharing, MOU. We found very few MOUs here for a lot of the work we talk about. I'm doing another project on domestic violence and child welfare. Again, very few MOUs. And MOUs tend to make the work less relational and more institutionally embedded, right? Because everybody knows coming in new, leaving. A lot of you talk about leaving in 6 years, 8 years. Someone new comes in, how will they know where to pick up and what are the rules of engagement if things aren't written down? Cross-training and then ability to break funds. We will not blend funds, but thinking about braiding is okay because braiding protects the funding source, but it then gives you the flexibility. And that's what System of Care did. SAMHSA was the first experimenter through System of Care to braid funding across different funding streams. And so there are ways to do that without losing the integrity and the accountability, which is what the federal government worries the most about when they give money. Okay, go to the next. So nationwide, there's a huge shortage of behavioral health staff before COVID hit. Right? deep shortage, high shortage areas, severe shortage. Look, most of the US is in severe shortage. The bulk of the country. So then what happened when COVID came? It exacerbated everything. I can't tell you how many organizations you work with who say our frontline staff would rather go work at the Amazon fulfillment center and make $19 an hour and have education benefits paid for than work in group homes or other really challenging delivery environments. Here, talking a little bit about the overlap between behavioral health and child welfare populations. This is not new to anybody in this room. This is national data. 7.5 million children each year are the focus of a Child Protective Services investigation for suspected maltreatment. Those children suffered at least one adverse childhood experience, more likely to have experienced at least 4. Up to 80% of children in foster care have behavioral health issues. 70 to 85% of children served by the child welfare system who are in need of mental health services do not receive such services nationally. So you're not alone. Nevada is not atypical. This is something that every state in the nation is confronting right now. Children under 3, even less likely to receive need. So it was really exciting to hear the 0 to 3 folks in the room because that's a real pressure point. And then instability in placement. More and more states are being threatened with litigation because of 2 things. So hospital overstays, because there isn't anything to step children down to, and or multiple placements, because it's not possible to stabilize children because their mental health needs are so acute, right? So that's sort of what you're seeing here. Any surprises with any of this data in this room? You all are experiencing the same thing.
I just add one piece of this on the children under 3 and back to the upstream and family supports. When we pulled our data around when kids were entering the system for Medicaid as child welfare kids, the percentage that were coming in really early was very high. So just really focusing on this needed, and it's not going to solve like the huge problem of a teenager in need of services today, but to help, just be cognizant of the fact that we're getting a lot of kids in early on.
I mean, to think about it, if a child gets suspended from daycare, there is something really wrong with that system. And overwhelmingly Black and brown kids are getting suspended from daycare. It's a problem. There's a disparity. There is an issue here, right? And childcare centers aren't equipped. And then where's the mental health? Why is it not the services not reaching these childcare facilities and centers? So let's go to the next slide. So here are the things, there are workforce challenges, we know, extraordinary workforce challenges. I'm going to do the blue first, and the green is where the opportunities are. So for the blue stuff is where the problems are, right? Access and eligibility barriers. Huge access and eligibility barriers. You don't always know that we work against each other. There was one state where I'm working at where they created this amazing targeted case management free benefit for DPED children. Then they said the child has to have at least gone to the hospital 2 times before they were going to approve the benefit triggering. And that's how they framed the Medicaid rules, right? The regs went forward and CMS approved. So now they have to go all the way back to CMS and get approval to change that. But those are the kinds of things that inadvertently, someone thought it was a good idea because it's a deep and expensive service. So let's put these guardrails, but then they're counterintuitive to the needs of children and families. Fragmented services between child family serving systems and behavioral health. Opioid epidemic and the impact on families be catastrophic. We talk about kinship care, more kinship care, more kinship care. Well, you can't get to kinship care if you're not supporting these families. And our own ability to take risk is really fragile. I'm just going to say that as public systems, who are always at risk of bad things happening when children are in our custody, we are not always, we're pretty risk averse, right? And to leave a child in the birth family is often quite risky. You don't have services to support them. Gradually growing menu of evidence-based practices, but not enough. Behavioral health actually has more EBPs than child welfare does, but that menu is growing. right? But EDPs aren't always tested with brown and black kids either. So that presents its own challenges. How do you create flexibility, right? But Congress is insistent that it has to be evidence-based, not evidence-informed. So that's where the funding is going. But there is value. I'm not going to take away. If everybody knows the Washington State Institute of Public Policy website, I would say go there, take a look at the cost-benefit analysis of EDPs. It's an extraordinary website that offers great value. Pandemic impacts, there's been an exacerbation of mental health all the way across for children and youth. And there's a ton of money coming down, right? Safer communities, SAMHSA's got money, CCM, the CCBHC models, physical-based wellness, the partnership between schools and behavioral health got to be as close as you can possibly imagine. Schools are very trusted spaces in which children and families can seek services. They're very trusted, but schools really know education. Social emotional learning is something that they should rightfully expect behavioral health to step up and give them that support. Limited data sharing, confidentiality, privacy is enough that must be cracked. It's not impossible. People have done it. But again, it's a question of risk, right? I think even the federal government is a bit schizophrenic on this. We're gonna come after you for breach. Go share. They've never figured out quite how those two worlds really well sit together, right? Shortage of crisis response and stabilization. There's a lot of push for that. There is enhanced match. And then lack of parity. This is a big one. There's lack of parity between what Medicaid offers for behavioral health and what you get from private insurance, right? So you could have parents who have insurance. They actually will take their kid to hospital, but their insurance will not authorize extended treatment. And the parents have no choice but to pivot to child welfare and say, take my kids so my kid can get services, not because there's any abuse or neglect in those situations. It happens in every state across the country. And so this question of where's parity between Medicaid and third-party insurance, and it's a conversation with the insurance commissioner, right? There might be other partners you need to bring to the table. And there may be other statutes that Congress has to look at. Opportunities, there is opportunity for policy and financing coordination. FFPSA, Medicaid, SAMHSA block grants, lots and lots of, there are so many different fund sources, and could we get to alignment? What would that look like? Increased recognition for impact of trauma in lives of children. So everybody's work is becoming more trauma informed. I think we're all becoming more trauma informed in the way we're approaching our work. So there's alignment, but there's also lots of things to think about. The next slide. Thank you. So we've talked about this. I think you said this in your opening comments. No system can do this alone. There have been those states that have been under litigation that have tried to build their behavioral health inside child welfare because they got sued. You can't fix it like that. You can't, because the financing for sustainability is going to come from somewhere else. So families and children often seek support from multiple avenues. They're going to knock on your door, they're going to knock on Medicaid's door, they're going to come to the hospital, they're going to go to a behavioral health agency, they're going to go to school, they're going to come to child welfare. They'll knock on multiple doors because they're looking for help. And we exacerbate their trauma by making them go through multiple doors, honestly, and tell their story again and again and again. The key to access and eligibility rests in building community resilience and non-threatening access points, such as in schools, in trusted community institutions and community-based organizations. States, public agencies are not always the most trusted avenues for entry for parents and families. They're always worried, right? Someone's going to take my kids away. Not that we want to take their kids away, we'd rather support them, but that is the myth, right? The living myth. And then all doors are open. What does that actually look like? And so that's some of the creation that will take place. Next slide. Then often children and families with complex socioeconomic and socio-emotional needs require much more responsive tiered system of care. One size is not going to fit everybody. And similarly, children, families, when they have good out, when you're increasing protective factors, improving health and well-being, that's where we want to go to both now. It's not one or the other. And then a clear articulation of outcomes and doing performance-based contracting. Very scary thing for nonprofit organizations, organizations that are partnering with the, because you can't do performance-based contracts if you don't have the data coming in.
And said admin. Sorry. And it said admin.
We're getting some noise from Zoom or from the team site. If you could mute yourself if you're not speaking.
Let's go to the next slide. So you actually have performance-based contracting, you have to do good actuarial analysis. So you know exactly what your risk corridors are going to look like before and after, right? That's important. And it takes a lot of transparency on the part of CBOs to share their data too, and for the state to then do the calculations. When I was in DC, we did that. We wanted to do, and when you're on a vacation, you get all kinds of mandates to do this and to do that. That was one of the things we had to do. So deeply into this PBC work. Due to the recognition of the, so let's take a look at multi-sectoral intersectionality. So you've got schools, behavioral health, child welfare, public health, right, sitting in the middle. Medicaid's a financing strategy. The service delivery is coming from all these other entities. And then there's the community and local systems of care, and then wrapped around it is the state, and then wrapped around it is the federal government. And you've got a very unusual system here, right? You've got Clark, and then you've got Washoe, and then you've got the rest of the state. And you've got a lot of variance across those three. And so there is not like good harmony about what this actually looks like, which is a challenge too for the state, and it's a challenge for the locals. Sort of, how do you negotiate? What does that begin to look like? There's much to be learned from public health prevention models to strengthen protective factors. And for a while, their Casey Family Programs was even looking at child fatalities as a public health, coming at child fatalities through a public health model, because prevention is so strong in public health. Behavioral health has led systems of care efforts that are anchored in engaging family and consumer voices. Now means here, your voice, you really represent parent voices. With FFPSA child welfare is moving up to prevention. Less about removal and more about building strength in families. And collaboration is often stronger at the local level than at the state. This is true. Why? Because you go to the grocery store, you're going, you're meeting the same people over and over again. There tends to be more stability in leadership at the local level than there does at the state level. So your relationships, we sense that too. In Clark, when we were having conversations, that team was all together all the time, right? But your distances in rural are really vast, and it's really hard to have the same sort of, the issues are similar, but the people are different. And the state has to manage all of it. So we got to figure that angle out too. Next slide. So this slide was a little bit confusing, so we tried to clean it up yesterday. Foster children are about 3% of the Medicaid population, but their Medicaid spend on somatic care is 15%, and the Medicaid spend on behavioral health is 30%, nearly 30%, right? So the prevalence of disability among child welfare involved youth ranges from about 14 to 47% of the population. That's what we're trying to say is that our children in foster care tend to have overwhelming behavioral health. That's really the point of this slide. It's nothing more. Behavioral health expenses are 2 times greater than physical health. And then those, medication management is always a challenge, right? Children are overprescribed antipsychotic medications, psychotropics, anti-anxiety, right? ADHD medication for ADHD. But sometimes the physician doesn't know, their primary care doc doesn't know what's happening. So that integration is also a gap which causes issues. Let's go to the next slide. So states where children and youth in foster care are covered, this is type with it, through specialized Medicaid managed care programs. There's emergence of Medicaid managed care, and then we'll slowly be going into those, having more of that discussion for individuals with special health needs. Special programs for children and youth in foster care, and then many states are already covering mandatory enrollment. Some have voluntary enrollment. So, and we'll learn more. Matt's going to walk us through all of these different models later, so that you have a clear understanding of what the possibilities are as you enter into your deliberations about options. That's some future. Go to the next slide. So these are the different funding sources for children and families that offer services, right? So CMS 1159, 1950, 1115, the spouse, right? Children and families, there's 40, FFPSA, Child Abuse Prevention Treatment Act, Adoption Safe Families, Social Service Block Grants. Some of these, like SSBG, is also used for adult protective services. I don't want to say like this is exclusively meant for child welfare, but and then from SAMHSA, you've got the System of Care Expansion Sustainability Grants. There's Project Launch. There's a new portfolio, Project Aware, which is for school-based behavioral health. State pilot grant programs for treatment for pregnant and postpartum women. Planning and developing infrastructure to promote mental health for children, youth, and families in tribal communities. Let's go next. I think with that, keep going. Okay.
Yeah, a couple.
Okay.
Just a couple more.
All right. So, System of Care is a national movement. You must have had System of Care grants about it too. Grew out of Advocacy many years ago. In essence, it includes efforts to work with the community framework to design, implement, monitor, and refine the system. Lots of big words. Sometimes they're 5-year grants. You can really make a lot happen. The problem is sustainability, right? When the grant ends, there's no way to pick that up locally or in your state. And so then, which is also, I think, why these conversations are happening. You've got ARPA plans over a couple of years, right? Then what happens? And so we really want to talk sustainability as we build the system. Whatever you're going to build or whatever gets built and shared has to have sustainability over time. Which is also why I know, for example, Cindy, you're doing some work with the Innovations Institute in Maryland, at the University of Maryland, and they're putting some ideas forward. It's good to connect it early because you don't want to go so far down with, a very generous benefit package. And if that Medicaid isn't early involved, then you don't know if sustainability is going to be there when those 2 years are over. And so I think you've already had a win in some ways that you have connected on that, it's really self-going. So foster care delivery system, there's the healthcare and the child welfare delivery system. And the healthcare, if it's fee-for-service, is one part. If it's managed care, it's either a carbon or a specialty plan. These are your options, right, that most states are looking at. And then in child welfare service delivery, there's either no privatization, so it's a state-supervised, state-administered system of care. There's some privatization, where some of the foster care case management services are actually privatized to large agencies who bear the risk. It's all about risk, right? It's sharing risk. And then there's full privatization, like in Florida. It's a fully privatized system for foster care. And so there are sort of these different variations of what happens and who's covered. Like, for example, in managed care, sometimes children in foster care are completely out of the fee-for-service, are in the fee-for-service system, and everybody else, even if they're child welfare involved, are in the managed care system. And so this, Matt referred to earlier, sort of how children move between fee-for-service and managed care in and out, is also an important issue to consider. Okay, let's go to the next slide. So now we start talking about states. Might I keep going?
Just on this one, and then I'll.
Okay, all right. We're nimble enough. Like, I can do anything. I can do that too, but just making sure I wasn't. Okay. So North Carolina put this very innovative waiver forward called Healthy Opportunities, and their Medicaid waiver sort of has these principles embedded in it, right? And which is important to all of you because we've heard you say this many, many times, and you said it again today. Interagency collaboration, accountability around results, individualized strength-based approach, child and family partnership, cultural competence, recognizing that we can't do this alone, so there are these community-based organizations that are part of us. Care coordination is provided both through managed care staff, but also through high-intensity services and wraparound, and their connectivity with child welfare manager. So guiding principles, healing individuals, families, and communities, and linked systems of care and informed decisions. Nothing here that you can argue with. We all suffered a paper. It's the execution that's always challenging. And they're still working on it. But this is a nice framework. If you had to have like a broad framework that said, okay, this is how we're going to approach our work, then you've got something here that might lend itself to some modification and adoption or discussion. Okay.
Now, yeah.
Now it's master. It's just whenever we get into Medicaid space, I get a little anxious. That's not my sweet spot. I can talk over all day long.
So, you're all probably familiar with fee-for-service Medicaid, but just to talk about kind of some of the, but sometimes too, what you work with gets so familiar that you don't kind of see the pros and cons of it, that kind of thing. So, this I think mostly you're pretty comfortable with, but this is where the state pays the agency or pays the provider directly, using their MMIS, their Medicaid Management Information System contract. You bill the state, you get your payment. It works pretty well in a lot of ways. Payments come quick, they come regularly. They're reliable, and states do a good job of this. Nevada does a good job of this, and a lot of states do a good job of this. The downside of this is there's an inherent incentive that's built in, right? You bill more units, you get more money. And so it's, and so your incentive is to bill as many units as you possibly can. There's not really anything that's tied to quality that's inherent in fee-for-service type approaches. And this is true on the commercial side as well as on the Medicaid side. Medicaid cares more about quality than commercial in a lot of cases. But, and most states kind of have a mix of this. Certainly the state I live in we've got mixed. Some pieces are fee-for-service, some pieces are managed care. Certainly that's true here. There's 4 states, there used to be 5, but Oklahoma is now moving to managed care. And there's 4 states that still are just 100% fee-for-service. And they're kind of interesting to look at, right? So Alaska and Wyoming, big, like Nevada, big rural areas, right? And they've just never moved away from fee-for-service. But they've, I think almost everybody that's under a fee-for-service model has recognized that it's got shortcomings. And they've tried to do things to manage care more effectively, even if they're not moving to managed care, if that makes sense. So Connecticut, in fact, they proudly call their program managed fee-for-service. And they've got some pretty good approaches in place. And Vermont, they don't use the same terminology, but they have a statewide accountable care organization that pulls in both Medicaid and commercials and puts some focus on quality and rewards providers who deliver better quality and who are more cost efficient. So they're managing their care, even though it's not through what you would think of as a traditional managed care approach. Alaska too has done some pretty innovative things, especially with their tribes, and especially as how rural it is. They've done things to get people care coordination and get people community health workers, even when they're out in the middle of nowhere where you've got to fly into or boat into or walk into. There's no driving. So it's interesting that pure fee for service is kind of a dying breed, but there are ways to make it work, for a state, and it depends on your state history. Here, you're using behavioral health. You've got behavioral health under the managed care organizations in Clark and Washoe, but most of the children, the children in foster care certainly are in fee for service. Most of the kids with high behavioral health needs are under fee for service. Next slide. Managed care organizations. I think you're probably familiar with this as well, given that Clark and Washoe are under managed care. But the important part here is that it's when you think about managed care, you can draw a distinction. There's managed care, which means the company is at risk. So, if you have Molina or United or whoever it is, they're taking on risk for serving the population. The state gives them, whatever the dollars are per member per month, and they've got to take that money and deliver care, meet the terms of their contract, and if they don't, they lose money. That's kind of as distinct from what's called an administrative services organization, and I'll speak to this a little bit later. And a lot of states have used that for behavioral health or for serving children under foster care because companies perceive that as too risky. They're worried about those costs. They're worried they're going to lose their shirt trying to serve all these kids or whoever it is with special needs. And so that means you're just paying them an administration fee. They're not taking risk on the benefits. The state is taking the risk on funding the benefits. And they're responsible for all these things that you see up there. That establishing the networks, network adequacy is a big deal. We'll talk about that a little bit more. Kind of the baseline for network adequacy is just if you're looking at time and distance, right? It takes you 30 minutes to get to a provider, it takes you an hour to get to a provider, it takes you, however long it takes. Or you have, X number of providers within 30 miles or 60 miles or 100 miles or whatever it is. And that's fine up to a point, but it certainly doesn't tell you the true story. As an example, right, you might have 30 miles, but it's across a lake. And unless you're like gonna get your speedboat out and go over there, you've got to drive around the lake to get to the provider. So those are rough and ready measures, and there's some more that you can do with that. Providing care and case management. This is kind of a state decision that's an interesting one on managed care, because you can have the managed care company deliver that using their own staff. There's pros and cons to that. Or you can have them contracted out to care managers that are provider agencies. And there's pros and cons to that. Every managed care contract has to have a quality plan. And so you have to have quality standards and you have to review service utilization. This happens today with the managed care contracts that you've got in place. But if you're doing that for a foster child or a child with serious emotional disturbance or that type of population, you don't want to be looking at the same things. Some of the same things are going to be still important. Yes, you care if that child's diabetic and their diabetes is being managed, or if they're asthmatic and their asthma is being managed. And yes, you care about hospitalizations and those types of things, but you care more about behavioral health, and you care more about those types of things that you see with the kids you work with every day. Regardless, you've got to measure the performance as it's determined by the state contract. And so it's important to have how you author that contract. There's the potential to create incentives for members to access appropriate care. And we'll talk sometimes under this final bullet, under what's called value-added services or in lieu of services. So like managed care companies, these aren't a Medicaid benefit, right? But for new moms, right, like they might have they do baby showers, right, and new moms will get diapers and things like that from the managed care company. It's not a Medicaid benefit per se, but it's a great thing if you're a new mom, especially if you're a new mom with not a lot of cash, to be able to get as part of your Medicaid benefit. And then in lieu of services, the most common one is states that use this to pay for psychiatric care, so inpatient psych. Which I won't go into the IMD exclusion right now. That's a whole other hour topic. But states have used in lieu of services, meaning I could pay for this inpatient psych treatment for 14 days, or I could struggle to meet that child's needs in an outpatient or adult's needs in an outpatient setting by paying for a whole bunch of other services. So if there's one kind of service that's more effective than another kind of service, then with CMS approval, your state can pay for that as an in lieu of service. And there's interesting things that different places have done. California has paid for a lot of homeless services using in lieu of. There's all kinds of things you can do with that. You can do an awful lot around access. And access, I know, is a hot topic here. It's a hot topic in practically everywhere. But you can go beyond just those time and distance standards, those basic elements. You can incentivize plans and you can say, if you don't meet this level of access, then it means that you're not getting as much money. That's one way to do it. Or you can say, if you don't meet this level of access, then when we're assigning members to your plan, which is, each member comes with a per member per month amount, then you will have fewer members, and that, and that kind of has a built-in incentive for the plan as well. You can also require plans to report metrics and post them publicly. And this, and this is an important one because plans can, right? I mean, one, families can look at those, or members can look at those as they're choosing their plan and say, I want the plan that has all the, that has all the stars associated with it, or has all the green boxes, not the one with the yellow and red boxes. And so that's an important way to do it. It's also meaningful just because they want to maintain their public image, right? If you're a plan, you want to be known as the one with the green boxes and the lots of stars. But the contract, it all comes back to the contract requirements. You've got to write these really tightly. And it's not that plans are, it's more that, plans are kind of don't understand what the expectation is that they're trying to wiggle out of something. But,
Okay, nothing really sounds good.
oh, and we've got somebody off mute again. So if you're intending to be off mute, then please speak up. That's fine. But
I don't know if we're gonna get. Go ahead.
oh, sorry. Were you trying to speak? Oh, maybe they were just accidentally off mute. Okay. Next slide. Here's a couple of examples. So Arizona has a plan that is serving children with special needs, children with behavioral health needs, and they require their contractors, if they can't get access within the network, they need to go outside the network. This is a pretty common way to do things. And so, and if they do go out of the network, they've got to pay 130% of the fee schedule. So there's an incentive built in to have an adequate network, because you don't want to pay 130% when you can pay 100. But above and beyond that, they also require reporting to the state around how many times they have to do that, what that looks like, so that the state can work with them and say, okay, this is a performance issue plan. Let's figure out how we can address this so that you have a more robust network. That's one way. Tennessee is, which is, long time managed care state. They have 100% of their population under some form of managed care, although they won't tell you, but I will, that some of that population is still getting services through fee for service. But they're proud of that, and rightly so. But they require their MCOs to build a workforce development plan with the state. This is increasingly common. Mississippi, Louisiana just did rebids, and they have workforce development requirements in their contracts. This is something that as nationwide, we're all feeling these workforce pressures. Managed care plans are being asked to do more as far as workforce development goes. They've got a report on late and missed visits to monitor service availability. So like if you have, and some of you might have familiarity with this problem, right? Like, great, you're authorized for 20 units of whatever service it is, but you can only use 5 or 10 because that's all the providers that you can find to meet, They monitor that. That's not the end all be all, right? There's lots of good reasons why you might only use 5 or 10, maybe you only need 5 or 10, but they monitor that as just kind of an indicator. And then they have some strict requirements around access. So you've got to be able to get into intensive treatment within 7 days, psychosocial rehab in 10 days, access to crisis services, 2 hours for emergency services, 4 hours for urgent but non-emergency. And then we'll talk about this a little bit more later on, but it's interesting. They've got a special needs plan that's specifically for children and others with special needs, but they're transitioning that to their bigger program. They've got 10 Care, which is their big managed care program where almost everybody is. And then they've got 10 Care Select, which is the, kind of the special needs plan, so to speak. But they're really kind of trying to move it all under one and make sure that their contractors are know what they're doing and have the right processes and procedures in place to serve everybody.
You know, there's a question in chat
Oh, great.
from Dan Musgrove. Do you see a difference between a managed care organization and a care management organization for children's mental health?
Yeah, that's a good question. So Dan's question was, is there a difference between managed care and care management organizations? Yeah, you can have managed care that's basically just kind of a duplication of fee-for-service. Like if you go back a lot of years, that's kind of how this program started was, okay, we've got a contractor in place, but they're just doing fee-for-service. They're not really taking on a lot of these additional responsibilities. Now, I think it's very unusual to have that. There's usually some kind of care management responsibility that attaches to the plan, whether that's the plan managing providers or whether that's the plan doing that themselves. Other questions on this, or?
I had a question for you. Where do you see the juvenile justice population fitting in this conversation?
I think, juvenile justice, you can pretty much presume that there are some behavioral health needs if a child is.
Right. But I know the exclusionary of some of the allowances within juvenile justice. Is that the reason why maybe it's not here, or is it Medicaid, or?
I'm not sure I'm understanding.
Well, some Medicaid won't pay for juveniles in facilities, so.
Oh, okay. Yes, I'm with you now. So if you're in an institution, right, Medicaid has an institutional exclusion. So if you have a child that's under juvenile justice custody directly, then juvenile justice is responsible for the care. Medicaid isn't. There's some movement towards waivers and trying to be able to cover, at least some of that, like pre-release or something like that, or being able to, or it's always been the case that if a child is, going outside of that institution of juvenile justice to an institution that Medicaid can cover, then you can pay for that. But it's complicated to coordinate all of that.
Before we move on, Angelica, you should be able to mute everyone except yourself in Teams, so that person that is not understanding the mute button. So you should be able to do that within Teams. I think it's mute all except self or something like that. I think we should, when we get a quick break, can we do this now? Because there's also apparently a way for us to enable chat, because we do want people to be able to participate one way or the other. That would be helpful, I think, as well as figuring out how to let people in the chat feature. So we'll take care of both of those.
Yeah.
We're not far from us.
No, I think we've got maybe a couple more slides, and it's probably right around 10:30, I'm imagining, so we'll probably get close to that. Okay, next slide. And there's, so you think about managed care, and a lot of the time you think, oh, managed care is managed care. There's different options with that. So you can think about carve-outs so like you can carve out pieces of fee-for-service, just like we do here in Nevada. You can have administrative services that I talked about earlier, where they're not taking on full risk. So some pieces are administrative services, some are full risk for the plan, those types of things. Or you can think about specialty plans, like you have a behavioral health plan. Those are decreasing. There's not as many of them as there used to be, where it's a behavioral health only managed care contract. There still are quite a few of those nationwide. A lot of states have done those under administrative services as well. But you can have those for behavioral health. You can have those for dental. You have a transportation brokerage that's carved out and is its own managed care plan instead of being part of the big managed care plan. Also, it does seem to be a trend too that people are moving to carve in some of into the behavioral health, into the mainstream benefit. So instead of saying, you've got physical health benefits here and behavioral health benefits over here, and there are different plans administering them, you bring them all together and you integrate them. And the idea being that you can do things like behavioral health integration and And a lot of states have done this. They've said plans as part of how we consider whether we're going to award the contract to you or not. We want to know how you're going to integrate physical and behavioral health under one structure so that you can make sure that your members' needs are getting met in both places. That you're getting physical and behavioral health met in a coordinated way, and that the PCP, the primary care provider, is talking to the behavioral health provider, that there's lines of communication open there, so that when the notices something like, hey, maybe there's signs of abuse or neglect happening here, they can address that with the behavioral health provider. There are lots of examples of this, and I think on the next slide, yeah, this gives you an idea of kind of what it looks like overall. For specialty outpatient, that's real common to carve in. Inpatient mental health services, that's common to carve in. You've got kind of some disparity or difference between carved out and carved in, but there's very few that just do outpatient only behavioral health anymore. The trend is really to do it all at once. And then same thing with SUD services and inpatient SUD services, but there's quite a few that are kind of a mix.
So those areas that are doing more blended with primary care health, are you seeing more parity coming in how those services are being delivered and paid for between the physical health and mental health?
I think in terms of like payment parity across physical and behavioral, I think it's hard to say. I wouldn't say that you'd see, behavioral health come up to the same level as physical health where they're doing that. I think a lot of the time they're just saying, well, the rates are here, the rates are there, and not necessarily converging on that. But I think the one thing that they are recognizing, right, is that if you're not meeting the behavioral health needs of the child or anyone, their physical health needs are going to be a lot higher. And so what some of these contracts are doing is they're putting in place value-based structures. So they're saying, if you provider are delivering better care for a person, and that means lower costs, and that we can see the quality measures of their care are better as well, and we'll share some of those savings with you. And they do that kind of in a coordinated fashion, saying the way to get to those shared savings is to make sure this person is getting better behavioral health care if they have a behavioral health need, not just let's treat the body in isolation from the mind.
The other thing I'd add to that is there's a lot of focus on social determinants of health, things like housing and food security and things like that are starting to become recognizing that sometimes poverty is a root cause for a lot of those adverse outcomes. And so when you put the three together, social determinants, health equity, behavioral health, and somatic care, and the value-based structures on top of it, then you're starting to see the opportunity for improved outcomes for whole family, whole person care. But I'd say the integrated plans, the research is still coming in, right? I think they're newer anyway.
Let me just add, California is on the cusp of that, so they've been working on their latest waiver is trying to get at provider reimbursement parity. And they're also, what's interesting about the managed care structure, regardless of what you think philosophy-wise about it, you can cover other things that relate to social treatment health. Medicaid state plan cannot, simply cannot. So when you bring all those together, I think California is an interesting case right now setting, because they're doing all of that right now in their managed care program. They're trying to integrate not just the services, but also reimbursement rates. We'll see how that goes. And then they're also adding in lieu of for housing and other things. We're trying to, in Nevada, add in lieu of for housing and our larger program following California. But California truly is the one state, I think, where you can kind of watch how that goes.
Just to add to that, CMS just approved California's great big waiver.
We're asking for them. We're like, hey, you can't just do it for them. So we're seeing how that goes.
Right.
Yeah.
And so like a lot of states, like Nevada, New Mexico, Utah, there's a lot of states looking at that and saying, let's do what California did, because that sounds kind of interesting. Yeah, especially around housing services.
And especially for children who are in foster care, as they're transitioning out. I noticed that we did have transition as one of the service offerings for those kids. But biggest offering that we can do for those children is to a very good transition plan, so that they are linked to those health services and they don't become homeless, and then kind of mitigate everything we've done for the past 5 years.
I'm really glad you brought that up. That's a really important point. That as you get to that transition, if you can make that, then that's huge.
So I'd like to see that something we can do.
We're working on that. I'm just pushing it.
And for later.
Yeah, there is,
So these are some examples of states and some of the managed care contract requirements that they've built in. So we've got Nebraska. You know, they have requirements for the screening, right? Like we heard from a lot of you on the stakeholder engagement. The screening was a big one, and that was a big concern. Monitoring treatment, information sharing, continuity of care, and prescription management. Right? We know way too many foster kids and kids with behavioral health needs are like on way too many psychotropics, right? This is kind of another one of the things that kind of argues for bringing it all together. You can manage the medicine at the same time you're managing the behavioral health and the physical health and do a better job, hopefully, at all three. Iowa, has done something similar with screening protocols, with comprehensive treatment, and so on. And then Missouri, identifying the population of a high risk of special health care needs. And they've got requirements that are specific to working with foster parents. So ensuring that they get those exams and get those interventions, that care management gets documented. They have an annual foster care report that they have to deliver. The plan has to show to the state, here's how we're helping foster families and foster kids. And they've got this integrated specialty plan serving that population. Next slide. And I think we are probably right. We're a little off sequence with the break time, but I think we're probably right.
Yeah,
around
right after
10:30.
this is correct.
Oh, okay. I'll hit this one then, and then we'll get the right side. All right.
Right after
Okay.
this.
So specialty plans. These foster kids use more services, and kids with SED use more services, and kids with behavioral health needs use more services. So you would expect that the payment to the plan per member per month is going to be higher to cover those services, and that's usually what happens. Also, I mentioned earlier that you have the quality metrics that are focused in on their needs, right? Like you're going to have things about screening for depression, anxiety, whatever it is, whatever the behavioral health need is. You're going to have metrics, and this is a common one that states are looking to, is how many psychotropics are these kids on, and using that as a quality measure. So there's things like that that are built into it, and then enhanced benefits. So building in wraparound, or building in intensive care coordination, or building in intensive home and community-based services as specific benefits in the plan that are there to meet the needs of those children. And then also, some of the things like supports for foster parents, so that the plan is reaching out to them. They have somebody to call when they're like, okay, I don't know what to do. That they've got that there. About a third of the states use some kind of specialized plan. Nevada is one of 8 states that's just using fee-for-service for this population, so that's kind of starting to transition away, it seems. There are a bunch of states that use managed care plans for children with complex needs, and there is a lot of opportunity here. If you're using these, you can create that accountability. You can, and I think the big piece here, maybe for Nevada, is that people mentioned over and over again in the stakeholder meetings that we had that things are bifurcated or things were fragmented, right? You put it all under one plan, that's where the responsibility lives, is with the plan. I'm not trying to sell you on managed care is the answer here, but there are advantages and disadvantages that I think are important to call out. That's one way to solve that problem and say, we're going to put this responsibility here. We're going to break funding from all these different sources, feed it down to the plan, and create clear lines of accountability. And I should stop because I get into this more later on. But that's one way to solve that problem. And let's see if Uma was right. So the next slide, a coffee cup. It is. It's a coffee cup. All right.
classes, if anyone wants to get a tour there.
think, Bill, were we able to get the,
I think we're good.
okay.
Yeah, we changed the permissions on here, so hopefully people are able to.
Oh, great, okay. It looks like you're able to put information in chat, and so if, I probably won't notice when you put up a chat, so if someone
I'm
else could.
watching it.
Zoom is monitoring the chat, so. Well, now we're going to move into some specific state examples and talk a little bit about those. And I'm hoping we can kind of, this has been pretty didactic so far, but I'm going to kind of, and hopefully we can start shifting a little bit to more of a discussion. And then towards the end of this section, we've got, kind of open discussion. So you could just go to the next slide. So this is around, we'll talk about behavioral health. We'll talk specifically about children and youth in foster care, and kind of thinking about that. Bill, you brought up the point that yeah, it's foster care, but it's bigger than that too. It's juvenile justice. It's children with SED. It's children with behavioral health needs that maybe aren't SED, but are serious emotional disturbance, but that could be. So
honestly, if children are in the custody of the state on the juvenile justice side, then they are treated like foster kids when they're exiting institutions, right? When they're exiting institutions.
So we'll start out with Texas. This was one of the first managed care programs specifically for children and youth in foster care. They integrated all the benefits. So like we've been talking about, they have physical, behavioral, dental, pharmacy, so they can manage the whole person care of that child. They did that through a single statewide MCO. That's really weird for Texas. They like to fragment everything.
It's huge.
Yeah, and well, it's a giant state for one thing. So that's a big ask of any managed care company. They got Centene, which is one of the bigger managed care companies in the nation. And they have 30,000 kids every month. So lots and lots of kids. The reasons they did that, these are going to sound familiar to you. They had a fragmented delivery system. They had problems with access. They didn't have continuity of care. They had services being duplicated. That's pretty inefficient. And they had challenges with the psychotropics, challenges with eligibility, and just poor communication overall. So, and then they didn't know what they were getting, and that's a big problem, right? If you're a Medicaid person and you're going to present your budget and they ask you at the legislature or at the director's level or at the governor's level, what am I getting for what am I paying for? You like to have an answer to those questions. And being able to point to some better quality outcomes. So this was one way that they tried to tackle this problem. Next slide. Another one comes out of Georgia. This one's, there's been a lot written about this. If you Google Georgia Families 360, you'll find a lot. And similar size, right? 27,000 kids and youth who are in foster care or receiving adoption assistance, or who are involved with juvenile justice. And the goals, again, are going to look familiar. They're trying to improve access to care, improve continuity of care, and get to better health outcomes through better care coordination. It was designed to support and achieve outcomes around a consent decree. This is one thing that, a lot of states have had the experience of this happening, right? If the state isn't doing this effectively, eventually somebody's going to come and say, state, you're not fulfilling your obligations, and we're going to have to bring a lawsuit to be able to do this. This happened in Idaho, this happened in Washington, this happened in California, this happened in Georgia. It's not an unusual thing. I will say it's, sometimes it's necessary, but it's better if you can get there without having to do that. It's because you can just work together more effectively. You don't have to have all the plaintiff and defendant conversations and so on and so forth. You can do it just kind of working together through, which I think is the opportunity that you all have. Is let's do this without having a consent decree over our heads. Then that's all to the good.
There's also, I will say, with consent decree, there's a lot of money that goes away from service to kids that you have to think about. But the risk is if you don't deliver, then I just feel like they have no choice. There is an initial boost in revenue for sure, but I'm not sure it's always sustained over a 10, 20-year period. In my own experience with litigation, you're sort of reaching plateau and then it's hard. You talked about being stuck for 10, 20 years. It's much better to create that creative energy in this sort of space. Because then there's always forward motion because nobody's going to help you in that space. If we can get it there, that's the better way.
And in Georgia too, they got a big national plan. AmeriGroup is Anthem, now Elevance. They're rebranding themselves as Elevance. But they were already there in the state. They had a presence, and so they were selected for this. Next slide. So they have this whole array in Georgia of additional services and supports. So they've got medical and dental homes, right? So those kids all have a medical home, all have a dental home. Dental home is big. Right? Sometimes kids, especially with kids with behavioral health needs or kids with IDD, right? It is hard to get them in to see a dentist. A lot of time they need sedation, those types of things. So they have one assigned for each one of those children. They know where they can go to get primary care. Know where they can go to get dental care. We've got a 24/7 intake line. This is huge for parents and caregivers to be able to have a resource to call anytime because kids' behavioral health needs are not scheduled. So that's pretty awesome. They have a medication management program, again focused on the psychotropics and on ADD, ADHD medication use. This is also really important because those can some of those drug-drug interactions can be really dangerous. And it's not just the psychotropics, right? But it's like, a lot of these times that these children have special health needs that require medications for a physical condition as well. So that's a pretty important piece. They have ombudsman staff available both at the state agency and within the AmeriGroup to support caregivers and members while they're trying to navigate. And this was also one of the things that we heard on the stakeholder input, right? Families are just like, I don't know where to go. I don't know who to talk to, and I don't have a guide, So if you have that navigator who can serve as or an ombudsman, somebody like that who can serve as your trusted guide through the system, then that is really, really important. And then kind of last but not least, they have these regional care coordination teams. So they've got a care coordinator who works with family services, who works with DCFS, their version of DCFS, with juvenile justice and with the agency to help them work their way through this. So really comprehensive array of services. Washington, I think, is particularly interesting for all of you because they had some county-based pieces to it, right? So if you're part of a county-based system like in Clark or Washoe, then this, there's probably some things to look at here and learn from, or maybe start brainstorming about. Reasons they're doing this, it's pretty similar across states, right? You're far from alone here, but the access, the coordination, all of that. So Washington was already contracting with managed care organizations for physical and behavioral health services, but they still were seeing this challenge and this need. And so they kind of thoughtfully moved into this phased effort to get county services into what they call behavioral health organizations. They call them behavioral health administrative services, or BASOs. And so they kind of put the county in the driver's seat a little bit so that they could expand their provider networks, develop the data systems that they need, integrate some of those administrative functions, and really kind of, continue with the role that they already had of serving children with behavioral health needs, but do it in a way that brought the managed care partners together and do it in a way that brought, all the pieces together, and with some responsibility. I mean, I think the challenge too to call out is, the counties now are having to do different things that they weren't necessarily doing before, and that can be challenging too. So they have this phased timeline to transfer in those regional networks into managed care for mental health services. And there's, some preliminary evidence shows some positive impacts for the children that are being served, for the people that are being served with behavioral health conditions. They also saw some improvements in access, which is a really good thing, in terms of primary care and mental health treatment and other things as well. Next slide.
Quick question.
Yeah.
Do you know if their school-based health services is carved in or carved out?
Good question. Do you know? I want to say it's carved out, but they're doing some things to bring it in within. Like, I know they've got some funding. I haven't worked a ton in Washington, but I know they've got some funding dedicated to like school-based health clinics and that kind of thing. And they're trying to pull that in a little bit as well. It's pretty unusual to have school-based carved in.
We'll check it out. We can do a bit of search.
Are these slides going to be available tonight?
Yes, absolutely. Sorry, I meant to bring that up as I came back from the break. I saw you taking pictures, and I was like, oh,
It
wait.
got too small, I couldn't read it. Oh my goodness, I better ask.
But yeah, we'll send these around after the meeting. And so this is an example. King County is where Seattle is. So it's like a big county in Washington, lots of people there. And so after they did this transition of funds to MCOs for behavioral health care, they allowed King County to contract directly with those MCOs to manage those behavioral health services. I think I get to California in another slide here. That's sort of a similar arrangement. But they've got an administrative services organization for crisis, because crisis is kind of a risky service to do. So it kind of makes sense to take some of the risk out of it. Not to say you have to do it that way. They've got some locally funded services for education and workforce. And then they've got what's called the King County Integrated Care Network. This is kind of what I'm talking about with the county acting as the network manager, right? Not kind of what you would typically think of a county as doing. But they've been able to get a more robust and stable network across all their MCOs serving the county residents. They've got multiple MCOs contracting with that network. And they've got a care coordination team that's working across the MCOs and the county. There's definite, and if this is something that you're interested in learning more about in the future meeting, one of our staff, Allie Franklin, she worked directly in King County. She knows an awful lot about this. She's done a ton of wraparound and working with this whole system of care. So we can have her give some more information on this if you're interested.
So this might be a basic like 101 question, but I'm like at that level. So in this model, state Medicaid basically funds money to the counties, and then the counties decide how to contract with individual MCOs.
Yeah, I mean, more or less. I think it's, and there's some complexities here, right? If you're doing this under managed care, then I think and I think I get to this like later on in the day, but you can do things like intergovernmental transfers between Medicaid and a county system. So basically you're taking those county funds, like those local county funds, and saying, those are our local match for our Medicaid program. And counties have this obligation to deliver these Medicaid services. You're essentially the provider. It gets complex.
Yeah, and we're currently paying the counties now. So it's just sort of saying, we're going to bring in a managed care entity to help develop the network, change quality, manage care, all those things, maybe do some better integration, those types of, like that's sort of the model of Washington was, there was some like pushback from the larger counties saying, hey, we still want to get our funding, we still want to be part of the solution, can we be part of this new model? And they came to this agreement with King County to allow them to say, hey, you can pick your managed care entities, you can do contracting, but the state still has a role in overseeing those contracts for the counties, yeah.
I think of it kind of like our partnership with ADSC, where they day-to-day manage the waiver program, but we maintain as a state, overall responsibility and work with BMS as, the administrating agency, although ADSC is the operating agency. So I kind of think of it, and maybe that's just helpful to the other state people, but that's how I try to conceptualize this, because we still do have requirements, HHS does, as well as state Medicaid agencies, and things like that, just to make sure that the services that are being paid for are being.
Yeah.
I have another one-on-one question, which is, you've mentioned NCOs and CMOs, I think, so managed care, I may not be understanding the acronyms, but I don't know, what is the difference between those?
I think managed care organizations just generally means a contractor that takes on risk to deliver services to Medicaid beneficiaries. If you're talking about a care management organization, then I think you would say care management is part of the responsibility that's attached to that NCO. So think of it as kind of a subset. Other questions? And also, I'm wondering, kind of Clark County folks, what are your thoughts on this? If you, I don't want to, point at you and say, hey, you're Clark County, you should know this. The Clark County folks, do you have any thoughts or reactions?
I mean, I guess I would just say, I think because we've talked on and off for years about whether or not managed care is an option. I think that we, or at least maybe just I thought that, I feel like this is a little bit of a conversation for down the road before we really define what our vision, I was thinking that we might be spending our time here talking about what our vision is, what our direction is, where we want to go, and then how we get there. I feel like we jumped to the solution in the presentation, and I wasn't sure that I was quite there yet.
Yeah, and just to be clear, I don't think we're saying this is the solution, or these are some solutions that other states have tried, right? In fact, none of the things that we're presenting are going to work. You can't just plug and play, right? None of this will plug and play with Nevada. Everybody's unique. Some states are uniquer. You've got a pretty unique environment here. You're very urban and then very rural at the same time, and so it's different challenges, and you have to adapt them for your states.
And I think today's purpose is to just do, it's literally like a one-on-one education of your own options rather than your solutions. Like, we're not doing that at all. I think what Cindy and Stacy and others wanted was to really just lay out, here's the national landscape, here's what's happening across the country. So that there's a level playing field when we do get to the point where we start thinking about recommendations and solutions. I don't think that's what we're doing today. So don't feel that pressure. If there are no solutions, nothing.
And I think on the teams, we might have some folks from Washoe County. I want to ask the same question for Washoe County folks. Any reactions? Oh, we do. Oh.
Sorry, I just had a question. So you talked about several different examples so far, right? And I get what you're saying. We're not picking today. We're not finding solutions today. But as we start to think about those as options, I guess I feel like I've heard lots of people talk about the potential benefits of switching to MCO for certain things. What I haven't heard is outcomes and in practicality, kind of what that really changes. And you talked before about kind of data points and so for these, it sounds like a lot of these are new. On one, you said there's some early data suggesting. Do we have concrete data to talk about kind of the difference in outcomes when communities have made these kinds of shifts?
Yeah, and I think there's some of that out there, and there's been some papers, and these folks probably heard about some of this at Nashville last week, right? It's starting to come in, but it's not to the level of, it's not like evidence-based practices or that level of rigor around it. But, you do see states that are measuring, progress on psychotropics and that kind of thing, that you'll see improvement over time, or you'll see improvement in hospitalizations at that. We kind of get to that here and there in the step today, but we don't get to, and here's the concrete, state-by-state improvements, percentage, et cetera.
I just had one thing to say. Sorry, it came late, everyone. I had a hard time finding the bill. Abby Pryor, part-time DSS. I agree with Jill and Sam. I think part of my question as we talk about these different options too is that my personal experience with a managed care organization, I liked it when I was well and I didn't need a whole lot. And I did not like it when I needed specialized care. So when we're talking about our highest need groups of kids, that's my concern, is that this model work well, or if maybe this model looks better for everybody, and then but we still need to figure out what to do with the IQ.
I would just say that the managed care program here is changing. I think the contracts have improved. Our last set of contracts are better. We're trying to get better social determinants. Health can get things differently. I'm not going to say defend managed care. I'm just going to say Nevada is improving that program. I think the one value of looking at what other states are doing is they're seeing specialized plans where the plan is only focused on the high needs population. That's a different conversation. I hear what you're saying, like putting everyone in the same product, and then you lose sight of the children with high needs. Like that makes a lot of sense to me. You don't want that, right?
Yeah, and
you want that specialty. Yeah.
Sorry, that wasn't even a criticism.
Yeah.
Criticism. I was just saying
No,
that was my
you.
question.
No, I hear you. I just want you to know, like, I do think there are challenges in managed care, not things not. But I do think Nevada has made a lot of gains in their last contracts, and it'll be interesting to see, like, over the next 3 or 4 years, do those things improve outcomes and how people experience managed care in the state.
But then for those children who are specialized foster care, what are we going to do for those particular children? Because some of the plans that they've talked about do have a combination. They have future services and then they have managed care for some of them. That's what I'm hearing. So that would be the decision. It sounds like we're going to be asked, you know, what of our population needs something more specialized versus who can be served in this broader category of managed care. It's hard.
Well, and what you'll see too is like states that do take like a big, broad approach. Like I come back to Tennessee just because I've been doing a little bit of work around Tennessee recently. But like, you know, they'll have this big, huge managed care program that covers the whole population, but they'll have little teams within the state that are focused in on special populations, whether it's, you know, foster care, IDD, whatever it is, to manage that portion specifically and monitor that portion specifically and make sure the plans are meeting the needs of those children, adults, whoever they might be, whoever it is with special needs, in a way that they don't for the general population. Because I think you're right. You know, the tendency is if you've got a single rate, you know, PM for the whole population, the plan is going to say, I've got to build something for the whole population that best meets the needs of the many, not the few. You know, and that can do a disservice. You know, that's something I think states have learned over the years as they've worked with managed care.
It would be great for us to look at what some of those states are doing and what the savings, the cost savings are, because everything really, you know, you don't want to talk about money, but it does come down to money. And so if we could see where those cost savings are and how those savings is used in other systems, that would, I think, help us make some determination. But I'm a provider. But it would help us, you know what direction is possibly beneficial.
Yeah, and that is, boy, cost savings are a challenging thing to track, right? Because you've got, one thing, it's kind of a moving target. You've got new populations coming in and out, you've got changes happening all the time, you know, and so you can't, not to say it's impossible, right? And in fact, Tennessee does make a lot of, you know, they talk a lot about the cost savings they've achieved. And if you look at, you know, their general funds over time for their whole program, not for a specialized population, it's relatively controlled compared to a lot of other states that maybe haven't done that. Of course, they've got their downsides too, right? Up until recently, they had big wait lists for a lot of their waiver services. And so it's like, great, you control your costs, but people went unserved. So, you know,
I actually think the value-based conversation is a better one than a cost savings conversation. So it's better to talk about what's the value that you're, you know, how are you incentivizing good practice? How are you incentivizing the right menu of service? Incentivizing good outcomes, you know? So I think that's a better way to frame this conversation than cost savings and did you reinvest those savings in other parts of the system? Because it's rarely that clean, right? You could not take 1915 funds and put it in a child clinic. You can't do that. Can you do different things with state match money? Yes, but if you're going to do value correctly and you're investing enough, if the system is well invested, then you can have those conversations of what happens to savings. If the system isn't, there's some under-resourcing in the system. So there are two things working, right? Leveraging those funds, well and smart, then are there enough resources? And so I think sometimes cost savings is I would stay away from that language, and that's what I'm
Here's what we stay away from those things that we shouldn't say.
But I think it's a really good point. It's like, what have you bought for your billions of dollars, right, that you've invested in your Medicaid program? And if you can point to, look, foster kids are on less psychotropics, they're getting, they have less needs for, for inpatient services, they're getting better, they're more, all of those things, that's a really powerful narrative. Be able to say, we spent our money well, and it's helped our population.
One of the things that I keep wondering about is how we're going to frame this during a time when the target is moving. Because we hear so much about how mental health needs are going up, and particularly for boys of color, the suicide rate is something like, for men of color, 162% higher over these last couple of years. So I'm wondering how we're going to be able to get enough dollars to support the population of boys that we see coming through our system.
That's a big challenge, and I think it's things like suicide, right, are just so multifactorial. And people will ask, well, where's your progress on reducing suicide? There's so many things that go into that. It's like you've got to be simultaneously upstream and at the point of crisis. And I think that's a lot of the challenge that this group will grapple with is, if you think about the need for beds, oh, absolutely, you need more beds. But if you only spend money on beds, you'll end up with a system that only delivers beds. And then, and you've got to focus on both the upstream and the crisis.
It's part of it, right? You're not going to do everything on once. So you got to give yourself grace, and you got to give yourself permission to sequence this. You'll have many pressures, and everything becomes equally urgent. But what we heard from everybody was beds. There's some piece of this that you got to do that's about creating some bed capacity. But then you got to rapidly move to the community system here. So I think you got to take these things a little bit. You're not going to have enough money to do everything all at once either.
And we don't even expect to do that as a provider of beds. We're looking at what do we do to keep kids out of the bed.
Out of it. That's the answer, right? Which is why
I don't like foster care, but I don't like foster care, actually. But we have it.
well, you have to put kids somewhere, right? So, but there is a bed issue. There is an acute bed crisis here right now. At least a particular type of bed, right? Like not all beds, but there is the conjugate, group, therapeutic, something. There's nothing. There, something, right? So child labor is not the answer to all things.
Matt, could we talk a little about the quality measures that get constructed into contracts? How does that work? Because that's a big part of what we do.
Yeah, I mean, that can be hard, right? I mean, the easy ones to get at are you look at claims data and you say, here's your quality measure, like rehospitalization, for example. They had an episode, they went into inpatient psych, they came out, they went right back to inpatient psych. Well, obviously something didn't work there. And so that's the easy example. And then you have ones that kind of are along that same track, like 7 and 30-day follow-up after inpatient psych. So you have, and you could say, managed care, it's your job to figure out how to make sure these kids, when they're coming out of that high level of care, get the follow-up they need. All of those are relatively easy to measure. Yes?
But I'm going to disagree with you a little bit. Because
Okay.
with our crisis is, you can go inpatient and you can get help, but then if you're discharged to child haven with 200 other kids who are completely dysregulated, 5 minutes later you're back to where you were before we started, then that probably had absolutely nothing to do with the care you received, but for the poor plan and the lack of placement that we had for you when you came out.
No, great point. And that's part of I think that's part of why you measure those metrics, right? Is the responsibility of the plan is to have that system of care there for that child when they're coming out of it, so they're not going to jump in. Yeah.
Yeah, I think the interesting thing about the quality metric if you want to do it in a different way, that's like bringing everyone to the table, there's a quality strategy, right? Every managed care plan would have one. The community is supposed to be engaged in that, so if there was the product, you would have, we hope everyone in this room would be engaged in what are we going to measure these plans against? What means outcome? What is value? They guys can plan. What do we want to see? And if they're not meeting those metrics, you can withhold payment. Like, I think that's also the cool thing here, is that there is accountability in a way that we wouldn't do to our accounting partners, for example, for good reason, right? But for a plan that has profit, it's doing really well, you can withhold that money. You can also require them to take their profits, reinvest it back in the community. And we could say, specifically behavioral health, right? So I think there's some value there that in flexibility to really get it, think differently, and have accountability that we don't have today. Not to say it's the only solution, I'm not saying it's a perfect solution. Managed care is never perfect. But I do think it's a different tool on the table that we don't have today. Think about how to build out in fee-for-service. I don't know if any state's ever done it really well, the managed fee-for-service state, but I'll be honest, I think it costs a lot for the state. And I worry that, as we all know, state government is understaffed, underpaid, all of us in this room. It's hard to build that capacity to do that insurance.
Yeah.
The reason I brought up whether Washington, I heard somewhere that they were looking at maybe some managed care school-based. And the reason why we wanted to look at that is we get a lot of feedback from parents that the community and the school-based systems are not integrated. So you have care plans on both sides of things, you have students with multiple plans. And so really trying to look at how do we better integrate between schools and communities for better outcomes for kids. And I was just wondering if a similar billing system actually helped with that, because, with two different billing systems, sometimes, like, people don't honor the school assessments, or vice versa, or, local crisis is fee for service and not managed care. So, the child is going between those two systems, the assessments and stuff like that are honored. So I was just wondering if, there are examples of states that have done that, that maybe it makes that integration a little smoother.
Yeah, I think the primary way people try to solve that problem is by saying, care coordinators, you need to be taking this whole personal look, and you need to be working with schools. That's a hard thing to do, right? I mean, schools can be their own kind of insular, right? Just like providers can be insular. And so if you have a care coordinator from the plan calling up the school, unless you've done the groundwork to build the trust and to build the expectations that, yes, schools and plans are going to be working together, and it is all for the benefit of the child, that, it can be a hard problem to solve. I don't know.
Some school districts I'm aware of are looking at community schools as being built into, not school districts, Medicaid has taken the opportunity to write community schools into some of their RFPs. I remember there was one that was written up in, I think either Missouri or Indiana, I can't remember which one, where they actually put that model in there, which is really nice. The struggle, obviously, is you want school-based health centers to be available for more than just Medicaid payments, right? So then how do you actually structure that in a way that makes that possible? Because for benefits, just to think about as if it wasn't enough to think through HIPAA and 42 CFR, for us, like pretty complicated lockbox, and it's hard. But I think to the degree that you all are doing community schools, I feel like there was one RFP that I reviewed where they actually have built that model into the managed care RFP. Tennessee did that too.
Yeah, I don't know if it's working, but they're trying their best. They've always had school-based health services in their managed care contracts, but they were not really requiring those plans to pay the same providers as the medical, it wasn't as explicit.
Yeah.
And so they've written that into their contracts more clearly now, where there's more accountability. But it is a challenge.
It's very
most states
challenging.
is outside of managed care, like what you're talking about. But I don't know how that's going for them.
It's a struggle too, right? Who's consenting? And is there a primary care doc outside of the schools? And we did this whole body of work for Delaware where we were trying to get them to redesign their whole school-based health centers or do a strategic planning process. And the primary care, the pediatricians were coming out saying, don't take over our role. You're there for physicals and you're there. because there is still the school nurse, which is a different role from that at the school-based health center. So there's all these nuances that you have to work out in that relationship, you know. But I always believe that the school health assets are sitting fallow after hours and weekends, and could be a primary care clinic in high-need communities for neighbors and parents and siblings. It's just the way you think about it, right? But for that, the health clinic has to sit adjacent to the school building, not inside the school building, because then access is easier for the community. If you've got to go on weekends through the school building, that makes it really hard. That's a capital issue. You know, there are so many things that intervene with like how easily can we get there. But it's a really nice model if we can get it to work.
Yeah, I mean, we're not doing school-based health centers per se really in Nevada. It's more strategy-based. So for example, nurses under IEPs or under 504s or care plans integrate the health right into the academic strategies as well as mental health. And we've kind of done it because we've had to, not that we necessarily really want to, because, you know, kids come to school and they're not getting their behavioral health needs met in the community and they show up at school. So the schools have to provide some sort of providers just so they can be successful in the school environment. But we also really want to make sure that those good partnerships exist in the community as well.
Yeah. When they do the IEP, do they reach out to the, you know, like, a lot of the time you'll have a school district doing an IEP for a child and meeting behavioral health needs within the school. But then they might have a behavioral health provider outside of the school, and never the two shall meet. Is that a problem that you see, or?
Yeah, I mean, sometimes. And then sometimes there are, schools have started to hire their own clinical personnel in the schools themselves. And so they can get some of the services right in schools, which has been really successful. But yes, I mean, all of the above, we've had all those complexities and challenges.
This is a particularly great time to think through school-based health, right? Because there's new funding coming down from the feds, both through SAMHSA and through Safer Community Fund. So, you know, both recognizing the suicide issue and the huge increase in mental health for children and youth. I think there's even, I think yesterday under, you know, AWARE plans, they're actually going to test out CCDHC models for schools. So there's some really interesting opportunities. I think this is the time to collaborate and think through what that design could look like. So
I was going to mention in Minnesota, we had an RFP that we put out and for providers in school. So we put language in the RFP that required that partnership, and the providers go right into the school. In fact, one of the statistics we found out, half the youth, that was their first time they ever had access to behavioral health. So, you know, schools is a great access area. You need providers in the schools to work together in a contract. That's what we did. One of the largest school health programs in the country. We use Medicaid funds for providers to use therapy and skill building. We had grant funds for when billable services were available, so it was a combination. Worked out really well.
They did a similar thing in Ohio too, over the course of the last 15 years. And they've gotten a number of the nonprofit agencies to buy in, and then everyone just essentially takes school. And so those folks are responsible for staffing, training, and all those good things. But they have to maintain that partnership with the school to make sure that there's integration of services and that all the kids are served, not just the Medicaid. I'd love to see something like that happen.
Again, it came out of a contract. You guys see, they had all the contract laid out. It's, what should we have in the design?
no, that's another thing to think through, right? New Jersey has done that really well, which is to use like almost like a ambulance model, right? Everybody gets the service that they need, and then the insurance issues are kind of reconciled by the providers behind the scenes. Washington State just passed legislation for mobile crisis requiring all private providers to pay for crisis services. And they actually passed it as law so that it wasn't just all going to fall into charity care or Medicaid or uncompensated care. So how far can you extend that scale? How do you bring the the payers, all payers, not just Medicaid? Because if you think about it, Medicaid's your most generous provider of behavioral health service. We talk about this all the time. Where does parity sit? Talk about parity between somatic care and behavioral health, but there's huge lack of parity between Medicaid benefit package for behavioral health and your private insurance, which is often, very, very limited. And so that's what causes parents to come knock on the door of child welfare, not because the child is neglect, but because they can't get the services they need. So if there is a certain accountability for those payers too. It shouldn't all fall on Medicaid. Children should not have to come into public systems to get the care that they need. So where's the accountability there? That's a question.
I know it's some that healthier payer mix too, right? Like
True,
yeah,
right? So it is in some ways you have to involve the insurance commissioner or the insurance administration in some conversation, but I would say there's a piece of it. In New Jersey's figured that out, right? Now, West Virginia just did this for children in foster care. If they have crisis needs, it was written into the managed care RFP. They're going to get the service. The provider has to give everybody the service, and then they can reconcile it at the back end. Who's going to pay for that service? So it could be something like that. Now, you'd have to control it carefully to make sure you weren't paying for things that the provider should be paying for, right? But that's the charge they've taken on how to do that.
So no refusal to treat things.
No refusal to treat. But there is a understanding that there would be a reconciliation. It wouldn't be uncompensated, or that the state's the one that's going to cover it all the time.
And if they don't take that, are they out of the networks then? Is that kind of like a violation of the provider agreement?
It's actually, it's with the managed care company. So it's the MCO that has to figure out how they're going to enforce it, I don't think. But the state is only working through the MCO.
Are the MCOs doing any early childhood mental health?
All of them are doing
They
early
are,
childhood.
okay.
All are required to do ECMA, ADLDD and ECMA, both, yes.
I have a question. Are you utilizing, we have a new provider type for schoolhouse services. Are you seeing that's a benefit as well? That streamlines the reimbursement for the schools to be able to directly contract with providers?
Yeah, I mean, we love our Medicaid partnership, and we appreciate that this law change to include PT60. The schools have been a little slow to uptake it. If you don't know, PT60 allows the district to build outside of the IUP. And so what happens is that we don't have to wait. We use multi-tiered system that supports language. So we don't have to wait until we're free or make sure that the child's in juvenile justice or special education gets services. They can get services when needed. And through this free care basically. So it's been a little slow because we don't have a system outside the IEP to track to make sure there's interest and exit criteria for kids moving in and out of the system and all that. But we are actually working with Michigan. And they've done something very similar to help build that system outside of the IEP. So we have 2 pilots going through Project Aware now. And
I think we should clone you and take you on a world tour.
But we're really excited. So yes, and just so grateful that Medicaid's been so supportive of the schools in the last couple of years.
I think especially in a state like Nevada, it's just such a great opportunity. And of course, it was reliant upon CMS expanding that free care rule, a couple of years ago. That made all of this possible. That I think it's just such a natural and right, kids here really need it.
We're doing a LinkedIn Live. It might be interesting to all of you on September 26th on school-based health. I'll send the link out to you guys and you can push it out. There's a managed care entity out of California that is speaking about school-based health, so that might be interesting, and you can ask these questions. And Delaware, which is entirely school health, state funded. So there are like these 2 models, and it might be interesting to see how it's playing in some models.
Well, really, last thing on PT60 so we're really excited to see, because right now schools are doing many of these services already, but they're using educational dollars to pay for it. So we're really excited to see if we can actually use, when eligible, Medicaid dollars to actually stretch our educational budget here in Nevada. So we're excited to look at these different buckets to see if we can, and then also diversify services, right? So we have more services in our schools that help kids in the schools and help youth.
So how does your education, I mean, do you have an infrastructure for building? Is that something you're building or?
We're building it right now,
Oh, okay.
yeah.
Okay.
Yeah. And the districts, in case you guys don't know, the districts use primarily PCG as their billing, and then also Infinite Campus as their student management, but what we're missing is an EHR, so that's what we're piloting right now.
Okay. Across the whole system?
Sorry, electronic health record.
Yeah, one each or?
Well, we're piloting two. We try to allow the districts to have their choice.
I think the next slide might be on California. We talked about California a little bit. Or oh wait, this is kind of the same. Going across slide for Washington. I'm jumping ahead of myself.
You want me to go back?
No, that's okay. Yeah. But similar concepts here. One thing I'd point out, they're doing health homes, and there's more about that later on. They have a behavioral health home, which is kind of think primary care medical home or patient-centered medical home, but think about that for behavioral health. And think about it. It's got a whole different array of services that are able to be offered under that. And there's some advantageous funding for the Medicaid program as well.
So Matt, what is your thought about the health homes? I mean, how much do you think they enhance your system?
I think it's like a lot of things, right? You get out of it what you put into it. And so just like with patient-centered medical homes, building one can be hard. But once you've invested in it and you've got it going, you can get a lot of return on it. So I think it's a great model. States have done all kinds of cool things with health homes. For IDD populations, for behavioral health populations, there's huge opportunities there. But there is this initial hurdle to get over where you've got to build the thing, you've got to get it going, you've got to get it, stable. And that's a real challenge.
Find your rate.
Yeah, but you've got to get the rates right, And there's also like if you're not a health home and you're going to be a health home, I think the hardest part of it is not even the rates. It's that you've got to figure out how to make your work processes work. How to change all your processes. It's just like any other organizational change, right? You've done this way for 10 years, but don't do it that way anymore. Now do it this way. And even if it's better, it's hard. Yeah, thank you. Let's see. Oh, I'm still in Washington. That's okay. There's lots of Washington. Oh, but wraparound. I'm glad, actually, let's stop here for a second. Because wraparound is a big one. We've got wraparound here, like a lot of states. There's wraparound, but there's not enough of it. It's a hard one because you've got to have fidelity to the model. And it's hard to build out. But they did this pretty successfully in Washington. And so that's one component of their model that I think is an important one. And then, the other pieces I think we've talked about a little bit already around the coordination around systems and the medication and so on. Now I get to California. But I think, kind of coming back to your comment about the suicides and disparities, right? Like California has done a ton with that, especially on their most recent waiver. And I think what California and many, many other states are realizing is, you don't address everything through a medical lens or a behavioral health lens. It's around the social, they call them social drivers in California. Social determinants is the more common language, but I kind of like social drivers because they don't determine, they drive it. But they're putting the attention on people's lived experience, they're putting the attention on the environment that you grow up in. All of that is just so important for your health outcomes. And so that's one of the pieces that they focus on both in their most recent contract, their RFP that they put out, and their waiver, which really fit together well. Not to say that California has this all dialed in and figured out. They don't. California's a big state and they've got a lot of challenges, but they're certainly doing some of the right things and moving in the right directions to try and address them. They've also got a county model. And over time, I think you've seen them kind of move to integrate what their counties are doing more into what the managed care is doing and what the state as a whole is doing. Counties were kind of off on their lonesome there, way back in the day in California, as mental health authorities, but now there's a lot more coordination happening. And that's been kind of, I think, a little bit that the state has been pushing on both counties and MCOs that you guys need to talk, and so that's, and they're starting to see some good outcomes from that. So, and some better integrated care. They just awarded their new contracts, so we'll see what comes of that. But certainly they're taking some thoughtful steps to get things aligned. And there is some integration, behavioral and physical health integration there that they wanted to achieve, and to kind of just streamline all of this. Next slide. And then, let's see, go on to the next one. These are some of the considerations around this. If, there's less disruption for the status quo with kind of taking a managed fee-for-service type approach. But there's fewer levers to measure performance and quality of care. You don't have the coordinated provider networks. There's state budget challenges with fee-for-service, right? Part of the thing about a managed care organization is they're a risk partner. They're taking on some of that financial risk on the part of the state. And so if you're coming and you're saying I need rates increases year after year after year, it's easier to understand if you're saying, here's our quality strategy, here's what we've achieved with our quality strategy, and the rates are going up over time, but generally managed care rates, it's easier to understand where the legislative audience a lot of the time. There's, transitioning to managed care for providers can be super challenging, especially when you have to, now you've got to bill 4 different payers or 3 different payers or however many different payers there are. That can be something that the states can address, but certainly that's an advantage for fee-for-service, is if you know how to build a state Medicaid agency, you know what they need, you know what they want, and you can do that when you want, especially if you're a provider who predominantly bills the state Medicaid agency, like most behavioral health providers tend to be, or some behavioral health providers tend to be. It also kind of gives the state some more control over rates. So you're able to say, here's the rate, that's what the rate is, that's what we're paying. Where if you're going through a managed care organization, if you're going to do that, you're going to have to go through what's called a directive payment, and that gets to be a hassle at the state level. So not to say there aren't ways to do that, but it makes it very simple. Like, here's the service, here's the rate, and we know what we're paying. And then also, you just have a single set of requirements. States can manage this under managed care. They can say all the managed cares are going to have the same PA requirements. All the managed cares are going to have the same credentialing requirements. There's ways to do that, but it is, it is simpler under fee-for-service because you've just got a single streamlined pathway for everything. So we already talked a little bit about the disadvantages. Here are some of the advantages.
So there is a comment in Teams about starting school later at the American Academy of Pediatrics.
I have a 13-year-old who had to switch to go to school an hour earlier this year, and it's just against all of evidence. But so I appreciate that on a personal level.
It's the importance of sleep, right? So I just wanted to call it out because I'm keeping tabs on Teams.
That's another one that I think California just did, is they moved school back an hour, so which makes a ton of sense. This is the biology of teens, and some of the rest of us too. So considerations around transitioning to behavioral health. overall, bringing it all together just, it makes a lot of sense to have it under a single contractor and do this integrated way. It does help with managing costs and containing costs and managing care. And it provides a lot more opportunities to offer those enhanced services, whether it's through, value add benefits or in lieu of or what have you. The capacity around data sharing systems, I think, is an important one as well. Because your managed care contractors, they've invested in national level systems, right? So they've got information systems that they can leverage and move out across states. There's disadvantages to that too, right? They've got their system that they built, at the mothership, wherever the mothership happens to be. They're going to want you to use the mothership version and not the Nevada version of whatever system it is. But on the other hand, you might be getting a system that you wouldn't otherwise have at all. So, like everything, there's a little bit of pro and con there. And then we've already talked a little bit about the quality strategy and the ability to measure performance. The MCO too, there's a lot of flexibility that goes with being an MCO. If you're a state, right, you kind of go to the legislature and ask for FTEs and funding and this and that and the other. If you're an MCO and it fits within your budget, you just go out and hire somebody and you pay the market rate. And so it makes things a lot more flexible and easy as far as staffing goes. And you can build that into your rate and kind of push that up to the managed care organizations and then go forward with that. But downsides, right? If you're a provider, you're negotiating a rate with the MCO. There's varying quality amongst MCOs about this. Some of you in the provider community have probably lived this. It can mean new provider procedures, right? If they're coming in and they've got a national program, they might say, we're going to have you do our national program. It might be unfamiliar to you as a provider. And then moving across the MCOs, if there's too much divergence between the MCOs, if you're a family, you might learn it for one MCO, but move to another for whatever reason and find out that you've got a whole different experience and now you've got to figure it out all over again. And then thinking the county government, we've kind of already talked about how do county governments work with an MCO. And then you also have some risk of duplication of spending on care management. So you might be spending on care management here under a fee-for-service piece. You're paying the managed care organization to do that as well. You're paying twice for the same thing or paying for something that's very poorly coordinated unless you really have your managed care ducks in a row. And this is Indiana is an example. They transitioned to MCOs for integration, but they had challenges around their behavioral health services and the networks there. And so they added some contract requirements to try and address that. And, some of this is, the time and distance type of thing, psychiatrists within 60 miles, but also things like encouraging providers to join the network to let them pay out of network, or, as the Arizona case was, requiring them. And then requiring plans to establish reimbursement mechanisms for telehealth, requiring plans to report on that, so that they're, continuing to keep their eye focused on them. For specialty plans, a lot of the same considerations as you have for just bringing it into the big plan. But again, that focus just on the unique needs of the population is important, and they can have different core competencies, right? If you're putting out to bid for a specialty plan, you're going to have different responses than you would for a big managed care plan. So all of these, some of these we've talked about a little bit. They also typically are more comfortable and familiar with paying for non-medical services and thinking about in terms of how do we work with CBOs, how community-based organizations, how do we do these types of things. But if it's one more plan in addition to the plans you're already paying for, there's a fixed cost associated with managing and running a plan. So there's that challenge. There's all the same challenges as kind of working across plans as you'd see with the other types of models. And it is a little bit newer. So, it's still kind of a work in progress. So, and Uma, how long do we have till lunch? What time is that?
13 minutes if we're doing lunch at noon.
Okay.
But lunch isn't here yet, so we could keep going.
Lunch is at 12:30.
So we have,
I think Angela.
Okay, so we've got 45 minutes. I've been standing for a while, so I'm going to sit down. But because this is the discussion part and the courageous conversation part where we kind of come back to where I started with around, being comfortable with being uncomfortable and kind of thinking through, what some of this would mean for you. But what of these pieces of other state redesign efforts do you think could be leveraged here? So, how would this potentially work in Nevada, and what kind of information do you think you would need? And this might be something that we could help out with as far as like looking deeper into other state models, bringing other information.
maybe ask people on the call.
The logistics question. I feel really kind of answered asking this, but where do we go to find what is involved in Nevada's NCOs? Like what components do we have? All of our contracts are listed online, and when it comes to in lieu of and value added services that we talked about a little bit today, we do have like a 1/2 pager that shows all of the differences of other plans. So I do think that is a really helpful thing to look at, just to see what different value added benefits our current plans are providing. Again, this population that we're talking about isn't in managed care today, but for the overall population, I think it might be helpful to look at some of the added benefits, and then they have to also provide all senior citizen benefits as well. So, but that's kind of the difference. And Stacey, that is available up on the web, right?
Yeah, but it's just our mainstream benefit, for not the option for children with services that we're talking about. You know what I mean?
Yeah, just our general
basic
population,
Medicaid benefit, right?
or that the populations that are currently in managed care. So, large populations, except for the discrete ones that are carved out. Kids that aren't in that, you can see based on the research with what they're doing.
And for folks on the virtual meeting, if you I think we've got you all muted, but you can unmute yourself if you want to join the conversation or bring something up. And putting something in the chat is also perfectly fine as well.
They can't hear us very well, there's or someone.
We do have some background noise.
So my question, what would be some of the first steps to move in that direction? How would you start that process?
One would be stakeholder conversations around like what are the concerns, how we might mitigate those. Really stakeholder engagement, I think is always the first piece of any well done system redesign.
Well said.
Like today and all of the other additional meetings that we're
So I think I'm never afraid to do that, so. I think going back to the questions I had earlier, for me, are part of the questions, right? We can say that there are these redesigns in these other states that are aimed at fixing project, problem X or problem Y, but are they really fixing it? And seeing data to show that, and is that redesign similar enough, or that community similar enough to ours to be able to say that that redesign would fix problem X or problem Y here, right? I think that's the hard part. Like, this is all just some vague idea out there. I think for me, when you think what information you need, like break it down on a day-to-day. If I have a child today who needs to, get into an RTC, what does that process look like under whatever new world we envision versus what it looks like today? And how does that help us eliminate the current barriers we have? But the other question that I think we're always not very vocal about is what new barriers does that create? There's always trade-offs, right? So what are the new problems we take on if we switch to a different model?
I have, my basic question is, if we're only one of 8 states, I think I saw 8 states that still use the fee-for-service, then why is it that everybody else went away from fee-for-service to NCOs? Because over my years, all I ever heard was we've never changed our fee for service rate. So is that like option, like a possible option up here? And if so, why can't we just increase our FFS rates versus revamp an entire system to MCO, pros and cons of that? Like,
So I would just say that it requires state funding. The legislature, we don't, Medicaid's not sitting on money to spend. We are allotted money for the population we are serving and the provider rates we currently are paying. So that would require new state funding. So that's the first step. You have to go get legislative approval for rate increase for these providers. I also think the evidence is shown, and if look at HMA over there, but rates aren't always a solution in quality. They're not always going to solve our problems. So I think it is definitely, I think regardless of what we're talking about, I think I keep hearing there needs to be more investment in, providers, which that makes sense. But like, what kind of delivery model and payment model do you want? Do you want a payment model that maybe says, instead of just paying you fee for service, I'm also wanting to see quality and want to see outcomes. How do we do that to providers that are barely making it right now, right? How do we get there? We're paying more for value and making sure that we're supporting them too. So yes, you can do fee for service rate increases, but I don't know if that's going to solve your problem. And you need to, with no income tax. I mean, I'm not from here originally, so in Minnesota there's income tax, state income tax. There's a lot of money to spend. Nevada, there's very limited revenue, and we have a flat budget in Medicaid. We don't get new money unless it's appropriated. So I think that's the reality.
And how does having an MCO change? I mean, it's not like that creates more money. You mentioned that it's easier to justify increases to the budget when there's an MCO, but it's not like having an MCO creates money, right? It just creates a private business, I assume, that's making a profit. And
You can direct a profit go back.
And there's premium tax too on managed care organizations, so there is some, revenue stream that's associated with managed care. So, yes, it's not like just moving to managed care is going to get you, however much additional appropriation everyone would like, but there are, like Stacey mentioned, opportunities to direct them as to how you reinvest, and we have done that for our broader, large managed care, and the most recent contract have directed them to reinvest 3% of their profits. You can do things like that, and then there is a premium tax associated with managed care as well.
And you can cover optional benefits with Medicaid funds if they're more cost effective. And a lot of states managed care plans add value-added services to attract or to be attractive in the RFP. So things that typically we can't fund or don't have money to go pay for in terms of benefits, we can push our managed care plan often to do that work. I think that is valuable. I'm not saying there aren't trade-offs too. There is value there that you won't always get.
You're right. I mean, it's not free. Nothing's free.
a follow-up question, since we have the MCOs for a large part of our population, that we have, you mentioned there an example where we said, don't you reinvest money in this specifically, but are we, I assume that comes up for bid, like that provider is every so often.
Every 4 years.
And are we good at holding them accountable to like network adequacy? Because something that I've just seen is when you have, sometimes when you have one provider of a service, they're actually holding the government almost hostage in that situation because there's no other game in town. And we see that, throughout child welfare often with, homes for kids. They want to give those kids a child even that are, higher level of care, right? But not the really, really hard kids.
I think it's an iterative process, and I think our most current contract is better than the one before that, and I think there's lots of opportunity. We did broad stakeholder engagement when we were putting our last RFP together, and would do that again. So I think there's always opportunity to strengthen requirements each time you do a managed care contract, and some more limited opportunity to amend the contract in between procurements. But I mean, it's an iterative process, and I do think the state has recently made improvements in contract requirements.
And so we have examples of holding that bigger MCO accountable, like during the 4-year window where we said you're not providing X, Y, and Z, and it's in the contract.
And we have abilities to withhold payment.
We do come out in our programs with really strong. We do lots of money for them, so there's more at stake. I'm not going to say it's perfect always, but there's more at stake that we can hold them accountable to. And the other thing I'd mention is that one value that we don't get with providers, is plan actually enters a contract with the provider. We don't have, like, I would say, real true contracts in our provider enrollment, right? It's a different type of situation. Those contracts can really spell out the effect of our provider system, our provider network. So sort of using that contracting tool too, that we set to manage care plan to also use for providers.
I'd be curious to know more, talking about spending. I'd be curious to know more about where Nevada sort of fits in comparison to the rest of the country. Where, I don't know how it's ranked on the Medicaid side, but like per person spending or per person, like, so we say, you know, and I agree, I mean, we've seen the experience of like just throwing more money at probably doesn't really necessarily solve the problem, but also if we're very low, throwing some money at the problem might solve the problem. If we're, you know, middle of the pack or higher, then maybe throwing money at the problem doesn't really help. But so that was one of my questions. The other question that I had was just thinking about, do you build the funding structure and the funding mechanism? Is it like, and then the services come? Or do you define the services and develop the services and then figure out how to pay for them? Like, what's the right approach? Yeah. That's my second question.
Sorry, I was just
Go ahead.
saying, my question kind of dovetails with your second question, which is like, looking at what do we need on the ground in Nevada, both in number of providers and categories. And I'd be curious about others, are there categories that exist in other states that don't exist here for types of service or provision of service? I suspect yes. And I'd be really interested in hearing what those are. And then like connecting to your question, once you have the map of like, okay, these are the agreed upon things broadly that we know we need. Information on kind of network adequacy and numbers about we're this far under where we need to be. And then what is the fee structure that supports that? I don't know if my question makes sense, but that's where I'm struggling to connect a little bit the discussion here to the ground where I am every day, where I'm thinking of a particular kid not able to access a particular service, and which of these fixes that?
I think, so kind of starting with the rate question, right? Yeah, I definitely think rates don't solve everything. You know, it's, if you have great rates but no accountability, you'll pay a lot of money and you may not know what you get for it, or you may not get anything at all. You know, but I also think what you're saying is absolutely right on. That, you know, if your rates are too low, no matter what else you're doing, if you're paying, you know, so that providers can't even afford to hire staff, you will never solve your problem. You do need to have rates that are adequate at a certain level. And to some degree, yes, it is. If you build it, they will come, right? Like, we've worked with providers at HMA who take a look at a state and say, should I go enter Nevada, New Mexico, Connecticut, wherever, you know, and say, and they're looking at it, and part of the math that they're doing is, are the rates adequate? Can I hire staff? What does the state look like? What's the state budget look like? You know, does the state have a good history of updating rates? Do they pay attention to rates? Do they periodically, you know, look at these over time? And so, you know, I think to some degree, yes, it's, if you build it, they will come. But there are also things you can do to influence that. And a lot of it is around, you know, provider burden and what providers have to do to get paid. So if you're able to say, you know, here's what you need to do to get paid, it's relatively straightforward, but there's some accountability built in as well, then that'll probably make it more attractive. But, you know, but as far as like, how do you know whether you're paying too much or too little? You can compare across states. In fact, CMS has a Medicaid Scorecard. If you go and look at that, it shows PMPM levels across states. But you've got to take that with a huge grain of salt, because every state is different. Every state has different eligibility levels. Just looking at a PMPM, well, you know, like if you're, well, I don't know, if you're a state that's got a very expansive program versus a very narrow program, that's going to make a big, big difference as far as like what you're spending. is. And they do, and on the CMS website, they do address that. I don't know, I think rates are necessary but not sufficient to solve a problem. This is kind of what I think it comes down to.
And in response to your question of sort of how much of what, right? That was an important question we're asking. When we did the short-term, long-term, medium-term, long-term based on our interviews, and that's why I feel like you've got a bed crisis in the moment that if you don't address it, right, like you can't stop there. And you don't have to build 100 beds to solve your problem. Maybe it's 15 beds, maybe it's 10 beds, maybe it's 20 beds. And figuring out what that sweet spot is, but you need something, right? Because your kids are going into childhood bed. And so there is an immediate problem. The issue of pre-authorization, provider enrollment into managed care, like it's a little bit, there are a few comments and teams where people are saying how hard it is to get enrolled with the managed care organization, of what are the simplifications. There's some things that could be rules and rule simplification. There could be other things that are, let's create, let's invest some money and put XYZ right now to give ourselves breathing room to make the longer change happen. And so that's part of the choices and decisions that ultimately will be in front of us. We're not doing that today, right? But mostly what we're doing today is learning the options and understanding what other states have done. But and also in response to your question, right? There is a lot of data about what works in managed care and what doesn't work. But like the pros and the cons of it. We're trying to give you like a broad level snapshot, but the data exists, or why would so many states start moving in that direction, right? There's an efficiency. When you say efficiency, everybody thinks cost, right? So there is a bit of an efficiency factor, but there's also outcomes rising and why value-based has become such a hot, phrase in this, because if you're doing value and we're incentivizing value, the quality of care is going to go up. And what does that look like? So I think there are answers to a lot of the questions that you're asking. In terms of what choices you end up making, that has to be uniquely responsive to Nevada. But when you have this level of a placement crisis, right, it's really hard. If you don't build upstream services, you're always going to stay in a placement crisis because those kids are always going to come deep end and there aren't going to be enough resources. So you're sort of doing both, so you can't sequence them, I'm going to do this, then do this, then do this. You sort of have to come at it together, but in the immediate, like if you don't have a few extra beds, you're going to really struggle. And so those 2 buildings that were being repurposed on the campus, right, that there was a licensing issue that was being removed, that was exciting because that would bring some beds online, that would give everybody some breathing room. I think last we were talking, the fire marshal was going to, those issues had been resolved and the fire marshal was going to come in and, approve the building. That's going to give you some room, right? It's going to just give you some breathing room to try to then do some of the other things that need to be.
So that's a good example earlier, and I didn't ask for any additional information earlier when you mentioned it, but you mentioned something about you should not try to build your children's mental health system within your child welfare system, but some states out of necessity are doing that.
Yep.
Well, that is a program that was built within the child welfare system.
Correct.
And there are 2 buildings on that campus now that we're building in the child welfare system, which is exactly the opposite of what we said.
To me, I personally, I will tell you, I'm a big fan of integrated approaches. The reason you do integrated approaches is because then every system leverages its own expertise.
We've had 2 phone calls that I know of from other people outside of child welfare asking me to take that in that program. And so, of course, that's particularly enraging to someone who asked the system to build this.
No, I get you, but this is.
But I guess this is why I'm asking though, is like we're down the path of the child welfare system building the children's mental health system. So I don't know how we
Back out.
reverse course
Yeah.
on that.
Well, it's a payments issue. You join hands, and if other people are willing to pay for beds, then, or, then you free up your money to go upstream together. Like, the question is moving forward. I think dollars are a hard one to integrate around, right? These are my dollars, these are my dollars, these are my kids, these are my kids. Unfortunately, no one system can do it alone. Like, they can't. I have lived through 2 consent decrees, and every time you get into consent decrees, you have to respond a certain way. And if other systems are not responding, you have no choice but to build it. I get it. Like, I've lived through that system. When I was in DC, we built the entire children's behavioral health system inside because we didn't think that the behavioral health system was responding to the needs that we had. And is that okay? You're duplicating resources inside child welfare. You're not quite effectively able to leverage the Medicaid, the disaster grant making, all that other stuff. That those systems should be helping you. I'm telling you, I'm owning it. I come out of child welfare. I think the risk that child welfare faces is so great, partly because they're not supported by other systems. They're not, right? So child welfare then finds itself continuously being sued. They're not the ones who can solve these problems. They themselves are underfunded and under-resourced. So that is partly why it's my own experience that I think siloed systems don't work. You've got to build an integrated approach to solving these problems at the systems level, at the community level, at the systems level, at the population, at the individual level. Like, all 3 tiers need an integrated response. And I think it's a flawed approach if you don't do that integration well. And if you're calling it out and you're sitting around the table, is there an opportunity to do a reset, whether it's through funding pipelines and eligibility redesign, right? Like, if you did human-centered design, Mrs. Smith is not just knocking on your door, she's knocking on 5 other doors at the same time. And she does not care. It's up to us to figure out how to make it seamless for her. It should not be her burden. Like, it absolutely should not be her burden. But we don't do that. So, sorry, my soapbox. I feel really strongly. Like, we do it. I think it's an unfair burden to child welfare, is all I'm saying. If it's not done right.
I appreciate that, and clearly I feel validated being the child.
That's why I did it.
But I guess, so thinking about like what are we doing here today, or like how do we move forward, I feel like us setting that, like that vision that you just described, I don't know if we're all there.
No, maybe not, but this is a starting point, right? Today's a starting point.
I feel like that needs to be what we all talk, like, I feel like that's kind of where we need to be before we're like, how do we pay for it?
Sure.
But I don't know, open to hearing, well, no, not actually.
So let me pause a minute. There's a bunch of comments on Teams that it doesn't take us away. We should keep that at the center. And, it's there, where are they? Just a lot of commentary here.
So your conversation is huge. That's kind of instrumental. Where you go.
But part of it is, so when we get stuck like this, and we're going to do this in a little bit, we bring forth some use cases, right? And you look at the real people at the heart of this issue. What is happening to little Johnny, or what's happening to, Susie over there? Like, when you put those real cases in the middle and you see how much duplication there is in problem solving, not in getting to the solution, because the solutions are tight anyway if you're not collaborating. But the amount of effort you're putting in the system to try to find solutions in a siloed way. Somebody's running around over here trying to find a solution. Someone's running around over there to find a solution. Each of those systems is a piece of the solution, not all of the solution. And so you could actually put that together. I used to always use this example of a child who's come into foster care. You're talking about doing reunification, and their mom doesn't have housing, right? Child welfare workers running around with their chicken with their head cut off trying to find housing that has little or no housing confidence. Mom is going to search for housing, knocks on the door of the housing department and a whole bunch of places, landlords, a bunch of places, right? And in the meantime, the stress of it's causing some level of decompensation. When you've got the housing person who knows what to do, how to get it done, and where to go, and everybody is doing the same thing, duplicating. Is there an opportunity to change that framework? Yes, there is. Absolutely, there is. This idea of a navigator that's shared across systems can be such a powerful asset. Because that navigator who's there with lived experience, that's why the whole peer idea has become so popular. With lived experience, that's helping communities navigate across these systems. Can't be that 23-year-old graduate social worker who can figure that out sometimes.
All the things that you guys were talking about, that puts our Nevada children's mental health system and our school systems in reactive and crisis mode are very similar. So, if you look at both systems, both are losing adults fast and furious, like we're losing the workforce, right? And many for the exact same reasons. So really looking at how can the two systems mutually reinforce each other instead of blame and shame and those kinds of things. Like we have teams currently that could be working better together. But I don't know if we know in Nevada because we've been so reactive, right? We're trying to put kids into bed so they don't get into bed. So then they show up at school and they create havoc at school and then, it goes round and round. Do we really know what interventions are working or not working here?
So one thought I have, and this is just take it for what it's worth, right? You take a couple of these very hard to serve kids, put a work group together and map their experiences across multiple systems. Literally just sit and map them, right? And see where are the log jams, where are the challenges. Maybe I've already done this, but across this group of, stakeholders, like literally map what's happening to these kids. And then when you use that human-centered design approach to map what's happening, then you figure out that, schools were doing this, and this is where we were having difficulty in child welfare, and the providers didn't step up, and this is the gap that we saw. And then you build your workflows for how you're going to work across these systems. Don't put something in a closed room because it feels good, but like actually go out and build that. You got to do some human-centered design workflows. Literally look at your workflows. Your assessment tools can be simplified. In Michigan, they had 160-page eligibility application process that they were able to synthesize to 10 pages using human-centered design. That's what you almost need to do something like that to figure out where are you all duplicating effort? Where is it not? It's lack of knowledge versus process log jams versus vacancies and gaps in not, just gaps in knowledge. There's so many things that I'm not hogging this stuff. Matt's got things to say. There's a lot of commentary coming down in Teams too that it's hard. We're collecting your comments, we're hearing them. It's just keeping the flow of the conversation going in a certain way. But people did want to take the PowerPoint down so that they could see faces and be more part of the conversation. Did you do that?
I just looked up.
No, but you took it out?
It's up here, but it's off there.
Okay.
I do have a question in this process. Is there a point where you get into this discussion about governance, with cross-agency collaboration, and what that means? Because a lot of it happens there.
It is governance.
So then you have a kind of a shared vision across these agencies, what you're doing as a group, not as individuals.
We asked, right, do you have a children's cabinet of some sort? Like all child serving agencies come together into but that was a bad, I should say, that was not a good experience. There's history there. So we will not talk about a children's cabinet. But it could be some structure. some structure is necessary, but to me, that's what you're creating around the table. You have to come to agreement that we're all serving children and families, and as such, these outcomes that we want to have of increasing protective factors, improving health and well-being, right? Managing transitions across systems, like those North Carolina values and principles, those are really show that, right? There's something like that you can have agreement around. You've got to create your own version of it. But if there's agreement on that, that then starts to guide the design elements for service delivery. And then that service delivery and financing in some ways have to go together, because you cannot just build without, you could say, hey, we're gonna have the best, this is what we want, the Cadillac version, when you only have money for a Ford Festiva. But does the engine work, and does it drive, and does it still take you forward? And today it's a Festiva, and tomorrow it's a Chevy Malibu, and then you're working your way up to a hybrid version of something. I don't know, like I'm just, you're dying to see.
Well, I am, because I'm sitting here kind of just frustrated, because I feel like a big part of it goes to Jill's point. There has to be a shared vision. And this collaboration that you're seeing around the table today, this is kind of a new thing. This isn't part of our culture, especially the way things have worked in child welfare and beyond, right? And so when we brought this group together exactly a year ago, at this very table in this very room, it was kind of in the vein that you talked about earlier. We probably could sue you and end up having to do a consent decree and go through all of that.
Yeah.
But in the end, we're going to end up at this table figuring it out together.
Yes.
So can we skip all that crap and just sit at this table and figure it out together?
Right.
But that is not something that historically, I feel like, has happened. It has been somebody in a white tower somewhere decides we're going to do it this way, and here it comes, and everybody else get on board. And I think that's part of why we have some of the problems we have. Like when Families First came up, like that's another example that I went to a conference 2 years ago, and there was a presentation by Colorado, who had been, all of their stakeholders for 2.5 years had been meeting religiously and developing statutory changes and figuring out how to maximize the potential of this federal funding. We've, as the agency that represents every child in foster care in Clark County, we haven't been invited to one single discussion about how our state is implementing Families First, and we're delayed in having it approved.
This is today, you're saying.
Today. And so I think part of our shift in culture here has to be the fact that we have to build it together. We have to plan it together, or else we lose the important different perspectives. So I'm grateful that we're all at this table having this discussion now, but I think, like to Jill's point, we have to find a shared goal and a shared vision to move forward, or I don't know that we get anywhere.
Maybe that's the first piece of it, right? Like, I feel like, and I hope everybody here agrees that, like, we've said it, like, nobody can do this alone. We have to collaborate. I mean, so, like, maybe that's the first part of our vision, right? And then we build on it from there. But, I mean, I do think that there's consensus around that piece, and if not, then we can have that conversation right now, too. But I do think that we feel like it has to be collaborative, and want it to be, and also just the realization of, if one entity tries to do it alone, it's going to stay fragmented and not really situating the population that we all care about. So I really like your idea about human-centered design, to put the family in the middle, and to have us come around and say, okay, in our system they do this, this, and this, and in our system, we go through, because you're absolutely right. The burden on alignment is on our families and our kids, not us. So I like that idea of making it very specific, giving it to foster care, and to really look. I mean, can there be one plan for child in foster care that we can plan instead of, 5 or whatever? One at school, one at community, one care plan, those kinds of things. One from juvenile justice. So I like that idea of that human-centered design.
I'm hearing two strains of thought, right? And then I know everybody can smell lunch, but we'll pause there. But I'm hearing two strains of thought. One is creating a shared vision, but why we're sitting around this table and what are the outcomes we want to get out of this shared work. So that's like one clear sort of statement that I'm hearing, right? And then the second is, what should be our process for going around and creating that shared, creating a roadmap, right? Like ultimately that's what it's going to end up being. And how do we use human-centered design principles in creating that roadmap? And once you've created the roadmap, then you can do a phased-in approach over time, right? Like we're going to tackle this first and this second and this third. But I will tell you, I mean, Matt may disagree, I don't think so. I mean, we heard remarkably the same thing from everybody we spoke with. This isn't working, we want to do better, and we want to do it with everyone else. We know we can't get it there alone. But then, not your self-interest, but your organization's self-interest and the people you serve often comes in the middle. It interferes. And I say that because you've only ever done it this way and your resources are committed this way, and to try to do something differently poses challenges. It really poses a lot of challenges. Like if you stop doing this, you might do less of this and something else over here. And who are the stakeholders who are going to make the most noise, and how do you manage it? Let's be clear, state government is deeply, deeply infused with politics. Always is. All your stakeholders and advocates, everybody's tugging and pulling at you. I've been there. I've done it. It's hard. Anybody who thinks government is devoid of politics doesn't know what they're talking about. So
They've never worked it.
right? Exactly. So let's call it what it is. Whatever. A black cat, whatever. I don't know. I mix up all this out of things. So maybe we're taking these notes, right? Like we're going to take these ideas and we're going to then figure out. There is a piece of this conversation that has to be an internal public agency governing structure. Then there is an outward circle, right, which is made up of your providers, right? But at the center of it all should always be the child of the family doing that design work. So I don't know what, it's a two-tiered structure in my mind. Like it's not a single structure that is both public and private all at once. It's too hard to move that because everybody has slightly different interests. But it is a two-tiered approach. You cannot do it without your private sector partners. But you got to figure out your internal core, like as a cabinet, I use that word again. As partner agencies, government agencies, what are your rules of engagement across all these different funding streams? And your own mandates, you have different mandates, child welfare, behavioral, Medicaid, you all have different mandates. How do you work those mandates into a more integrated framework? Then you have to figure out, right, what that in school streams. But what does that mean? With your providers, it's a two-tiered approach always, I think. You were going to say something?
I was going to say, I've noticed just globally that we all have a different ability to move at a certain speed. Like one program can move at a speed that this program can't move at. And so I find it hard to move in sync together when we're moving at different speeds just by design, I guess. If that makes sense.
Well, and you've all got different constraints and challenges, right? I mean, the Medicaid guys are familiar with Medicaid, right? It's like I know what I can do and what I can't do and how long it takes to get something through CMS and all of that. But, for Title 40, it's a whole different story. And for schools, it's a whole different story. And so I think it's less that you have to move all at the same speed, but that you have to respect one another's constraints and find out and figure out an approach that's going to work, not at the slowest speed possible, but at a speed that works for everyone. Recognizing that.
But I think that's part of the issue though, is that we acknowledge it, but we don't live it.
I'm not sure I understand it.
Exactly, well, and so if you think of it like for ADSD, we're service. You know, we're not child welfare, we don't have the capacity to have a child in our care. I mean, we're a service delivery model, and I think sometimes there's expectations on that service that will be the end all be all for that child, but really where every single group has to wrap around that child for that child's success. And so I think at times, as we all know, we're very bureaucratic as state government, but we forget which piece we're all doing, so then it becomes that frustration with each other, when really we just have to remember to take the step together. We might not be completely in sync, but we all have the same thing in mind. Wrap around that child, have that child be successful, whether educationally, behaviorally, whatever that is. But stop being so angry at each other for not doing it the way we think they should do it, because the system is not built just because we think that's the way it is. We can make modifications, we can make changes, but we have to be okay with it not always going to be in sync. But what are we doing for the child? Because doing nothing, we're all doing for that. But support each other and what we can do. And be kind about it. Because I think there's times, I mean, I'm newer to some of the conversations, but I'm like, wow, we are not playing well with each other. And so I think that we have to find a way to do that and just have the conversation and say, you know, Ricky, this is not working for us. Okay, well, what is it that we need? Before we just say, well, ADSD is not doing it yet again. So, but take our role and say, okay, but maybe we're not, but this is what we can.
So, you know, I used to oversee, I worked in state and I worked in county, and I will tell you, the closer you are to where the families live and the children live, the more you tend to think about centering families and children in the way you design those systems, right? So there is a lot of wisdom that counties have and your locals have, whether that's rural or Washoe or Clark, about what works and what resources are available. And honestly, I used to always tell my state partners, here's what I need, right? Your job is to give me that policy environment that makes it possible for me to execute on the plan.
Let us take the barriers.
Right, you take the barriers away, you figure out the policy environment, I will do the execution at the local level. And so there is that tug of war in state administered, state supervised systems that we need to know, we need to figure it out. And then you set yourself up a little bit for that tension with county, and counties set themselves up too. State, you don't know what you're talking about. So there is that dynamic as well that has to be worked through. I think you don't fix everything, you don't pick everything. You pick one thing, you say, okay, we're going to navigate the high needs cases. So pick a university cases, 100, 200 cases. This is aside from the financing issue, like not talking about that. Pick 200 cases across the state, or some number that are touching multiple systems. Take those cases and let's do an analysis of what's working, what's not working. Where are the struggles on those? 200 maybe too much. Take 20 cases. I don't know. I don't know what resources
you took
exist.
the air out of the majority of people in this room and you said 200.
Yeah. So pick 20 cases, right? And let's do an analysis of really where are those families and children getting stuck? What's missing? Then you quantify. We're all touching a piece of the elephant blindfolded, and we don't know what's out there, right? Somebody's the trunk, somebody's the leg, whatever. But if we sat together and sat in a room for, did like 3-4 days of analysis, like in a room, you got to get your confidentiality, privacy rules put together and do that kind of, but you got to pick a case that's touching multiple systems. Then you figure out, if we were to create a navigation function, what would that look like? That could navigate all these systems. And you don't do everything. You're not going to fix everything all at once, but you pick a couple of things that are going to give you some relief and start there so you have some wins, and then you can keep building on it. If you have no wins, you pick too much and you have no wins, that's also very hard because you get discouraged.
And I just want to add too on the wins, see where the child, how far the child has come. Because affect really some kids. And it's only about, oh, they went backwards. Yes, but they made these strides going forward. We're here to wrap around that child and that family and be child focused. I see we're more at each other than fixing. If we took that energy at that somebody's mad at each other, which we're adults, we're not on the playground anymore, or we're not in high school. If we take that focus towards that child, how are we not going to be successful for that child?
I hate to call the break, but I'm gonna have to because we've got, so we've got lunch and then we've got a chance to do some of that around some breakouts and some vignette, some kind of case study type options. But we have some other folks coming on from HMA to help lead the Teams group. So Teams folks, they're gonna come on and do breakouts via Teams because you have some awesome comments. It's just hard to coordinate a discussion across line and in Teams. So and I will break up the room here. Teams folks will break up with Paul and Allie. Paul was Minnesota's behavioral health director. Allie, who I told you about earlier, worked in Washington and has done lots with wraparound. So we'll be doing that at 1 o'clock. And so we only have a half hour to get lunch. So that's what I'm calling the timeout, although I sort of regret it because this is a really good discussion.
No, I was like, geez, I'm gonna hurt. Well,
It's hard. But not us here. Yes, we have a good.
Did you get the $20 million you were asking for?
That's yet to be seen. We got the passcode to get to the next step, to get to the next step. It's all hard, but if not us here, I would say us here.
the reason I asked that question is because cost analysis. And I've been working with folks to get all these, try to find these articles. And this was.
It is absolutely a priority. It's like why I do that explain too. It's all about governance. If you don't get governance right, it's a great problem.
Yeah.
It's an absolute.
So yeah,
I have even seen created systems of governance structures that have been absolutely failed. I'm very policies. Yeah, it's like that.
Yeah. Oh, yeah.
Yeah, probably, some point, yeah.
Yes.
I like I said, I work with.
But the structure is really nice.
What do you have planned for Wednesday?
All together.
I like it. I guess totally honestly, hang out. I used to have the
It's a good one, right?
Hang out for a while.
Yeah, I don't, here, that's what we're here. Yeah, yeah.
This, look at this. That looks awkward, doesn't it? I'm glad we're not there. What the shit has
My receipt from Walgreens for the shampoo, conditioner, and mirror after came out like $8. The mirror.
Yeah, right. Agree with them at all. I feel like we need to do that. On the, but our 30 motions really, because I tell her I do good first thing and then I'm like done my day. Like, if I feel like I'm like,
Not that it's not gonna be the same, but I don't know. It's some fun stuff.
I'll let you know.
Let me know, because I'm trying to figure out. That's what I'm here, I'm just like, and they want to know how does that work with how many data. I mean, we have really broad general.
I was
Awful. We're not
I'll ask the
We just did some regulations around process for suspension and we heard some advocates really give it like 2 reviews. Do you have anyone you look your office that take a look at it for us and see what you guys think about it? Yeah. Okay. Oh, that would be great. Yeah. Really, the interpretive law was from what we last year.
Yeah.
As far as
Welcome to the audio conferencing center. Please enter a conference ID followed by pound.
Once again, to see their queen just passing by, just momentarily, right behind me. And this is something that the British public has been doing for the past 10 days, especially these past 10 days of mourning.
I don't know who this lady is.